Good afternoon. This is Dr. Jayant here. Neil Batman. Mr. Neil Batman. Hello. Yeah. How are you? You're muted.
Yeah. No, I'm now not. Yeah, very good. Thank you. Very good. How are you?
Thanks a lot. How is
good
the situation there? It's getting better?
Yeah, getting a bit better. We are, things are, the sort of pandemic is winding down a bit, and we're now just faced with how we, cope with our backlog of patients. So yeah, and that's going to be a big challenge.
Hello. Good afternoon, Dr. Alan. Yeah, you're.
There we go. I'll mute myself.
Yeah.
Hi, Neil.
This is.
Hi. How you doing?
Yeah, good. Yeah, just making sure I'm working, logging on, because we've got so used to these Zoom and MS Teams and everything at the moment. It's amazing, exactly. Really, how it works out.
Yeah, exactly. You never need to leave your house.
Yeah, it's quite sad, really, isn't it? You get used to
It's really sad. It's really sad.
I kind of, especially with Baco recently as well, isn't it? It's all part of this sort of social stuff that you kind of get on with. But
I know,
it is what it is. Yeah.
Yeah. I hope it doesn't last forever, though.
No, exactly.
Was Baco? Was it good?
Well, I had to give a talk. In fact, I gave this talk actually, but it was recorded beforehand.
Yeah. Yes, that's what people were saying.
Yeah. So I mean, so I recorded. So there's no interaction as such. So you just had to record it, and
yeah.
Yeah.
I was there in UK till 2007.
All right.
Came back to India.
Yeah.
I was in Warrington and Birmingham.
Oh, okay.
Yes, but yeah, we're all. So.
It makes you realize with Zoom and Teams and online meetings how much of the good stuff in the meeting takes place, in between talks and afterwards, and just a bit of chat over coffee or over a beer.
Yeah, absolutely.
That's what it's all about.
Discussion. I mean, definitely, we're really looking forward to getting back to that at some stage.
God,
yeah. Yeah. Are you guys doing remote clinics everywhere as well?
In India, you're asking? Is it?
Yeah, in India as well.
Yeah, it's started. Routine clinics have been started.
It's really face to face. Yeah.
And we are getting second wave probably started. The cases.
Oh, really? Yeah. But, we're doing some remote clinics, but it's. I'm coming to realize that you actually still have to examine patients.
Yeah. But it's interesting, actually. I think, from the perspective of some of the general bump that we sometimes get, actually, it's been quite good to be able to reassure, and actually, especially the non-head and neck stuff. Patients don't necessarily want operations and stuff, and you think it's actually quite easy to discharge them when you know they're okay.
Yeah.
And suddenly things aren't as urgent as they thought they were.
Exactly. I think what we're doing is being way more aggressive with our triage. I think that actually that's and then it becomes apparent that most of the stuff doesn't actually need to come. You can just. So we've got one of my colleagues spends half a day a week just radically triaging stuff, just sending it back, saying, doesn't meet the criteria for tonsillectomy. No. Right to us when it does.
And that's the thing. So so that's been quite a revelation, actually, how much you can do, and especially with follow-ups. Actually, really found because I found it so wasteful in a way when you had to call a patient back for for a normal ultrasound or an
exactly. So that's what I've started doing is phoning, and it's the sort of thing where I for years I thought, we should just phone them, but never really got round to sort of setting up a system where that happened.
Yeah,
and then suddenly COVID happens, and 2 weeks later we've got here's a telephone consult system.
Yeah, exactly.
That's what it takes.
Yeah, exactly. Because before I think it was all stuff to do with payment and who does it at what time. You're going to just do it in your own time. Now actually it's a defined clinic that you can do this stuff. So makes sense. You've got your information on the screen. So it's good. Yeah.
Some progress has come out of it.
Yeah.
Do you want to check your presentations?
Yeah.
And your videos, if it is any.
Shall we just?
You want to go first?
Yeah.
Okay, I'll share this thing. Where's the thing? I'll get confused between MS Teams and Zoom because we sort of flip between them. Yeah, so Zoom's got the stuff on the floor here. So share screen. Shane, did that come up?
Yeah. That's right.
Fantastic. Excellent. I'll just... There are two videos. I'll just forward to them, I think.
Yes.
Let's see. Do you just see... are you just seeing the screen, as in the slide, or are you seeing the smaller slides on the side?
It's not a it's not a full screen.
Yeah, so it's just, you're just seeing the one slide.
No, we're not. We're seeing like the edit screen as if.
Okay, so that means
working on it.
Well, that's good. So I can do that later, I suppose. But I'll just get to the videos, make sure they work. Exactly.
Good evening, Buster. Good evening, Jerry. Yeah, it's working.
Good evening.
Is that working?
Yeah, it's working.
That runs nicely.
Great stuff. Okay, that's good. How do we get rid of some stuff there?
Hi, Neil.
There we go.
Hi. How you doing?
I'm fine. How are you? You okay?
Good. Yeah, good. Thanks. Good.
Thanks for joining.
Oh, pleasure. Absolute pleasure.
There we go. So mine's working. I'll leave it there.
So I make sure mine's working. Share, and we want. Let me just put that in like that. There you go. Can you see that?
Yeah.
Fine. Yes. Yeah.
Working.
Perfect. Good. I don't have any videos. I decided to keep it as stress-free as possible.
Videos are tricky sometimes. It's true.
Yes, I know. Having had a few where the videos at the very last minute didn't work. Thinking of.
I found Zoom is much better than MS Team. I think. I don't know what's your experience.
Much better.
Much easy to just easy to get into the system and operate.
Especially if you've got a Mac. MS Teams just doesn't. Play with Macs.
For some reason, our trust has chosen MS Team for everything. It's just
crazy.
A nightmare to.
I know. It's really difficult to make a keynote or a PowerPoint play the slideshow. It's like the number of times I've had to do teaching on MS Teams, and you end up just saying, "Well, you're just going to have to imagine this video," or you leave it on the edit screen and don't have a proper. It's very, very frustrating.
Yeah, it is.
Good.
Good evening, Thomas. Jerry.
Good evening, sir.
How's it going, Neil, in your department? You back to normal?
More or less. We've got, we're more or less back to a normal-ish timetable.
Really? Okay. Electives as well. Okay.
Electives. We're only allowed to do P2s, so only urgent cases. And that applies to the whole of Greater Manchester. We're not really allowed to do anything, same as you. But actually, so many of our standard routine cases have waited for such a long time that
I know.
They're being upgraded to P2. So kids with obstructive sleep apnea are being upgraded to P2s if they'd waited for a year. So we're up and running. Our waiting list is just horrendous.
Yeah, I know. It's really frustrating, actually. Yeah.
You guys will be the same. So what are you guys doing?
Yes. Just P2 and head and neck cancers now.
Yeah.
Head and neck cancers. And what I heard from Salford, they are back to normal. It's amazing how the Salford can pull things actually. Yeah.
Basically making their own rules.
I know.
Astonishing.
They're always ahead of game, actually.
Yeah. Well, they're just the law unto themselves. People have said, "Oh, this is what's happening. This is what Greater Manchester say, or this is what
Yeah.
NHS England say," and then you think Salford are just doing it differently.
No, yeah.
It's fascinating. I said, "Well, why can't we do that? Salford are doing that."
Yes.
No.
Yeah.
Greater Manchester say you've got to do this.
Yeah. It's amazing how they can manage, actually.
I know.
I was just speaking to a registrar yesterday, and she said, you're just back to normal. They're just doing mastoids and everything, except the plasties and tonsils. That's amazing.
Absolutely.
They can just
they'll do everything to protect their because they have this massive spine and neurosurgery service that they just say, okay, whatever, we're going to opt out of everything as long as we can keep as long as we can keep this running. It's fascinating.
It's amazing management, actually. The culture is so different there.
Exactly. I think they're a smaller organization. We're a massive lumbering.
I know.
It has some advantages, but a lot of disadvantages.
How they're going to manage the waiting list? How they're going to manage the long waiting list?
It's really interesting, actually. We in Greater Manchester, there is going to be one waiting list for the whole area, the whole region. So although there are a loose count of how many hospitals there are, what they're saying is there's one list, and each hospital will do their cases, but you can't be having one hospital being ahead of than another hospital. So the NHS is like massively driven at the moment to make sure that nobody's disadvantaged, which I suppose is admirable.
It's a fair thing to do, but it just requires a massive admin effort, isn't it?
I know.
There should be a massive admin team sitting and doing all those things.
So they've asked me to consider being the clinical lead for clinical lead for surgery in children. So all specialties of the surgery in children for Greater Manchester. And the time allocation is 1 PA. A half day a week. Are you
good luck, Neil.
You're joking. It's going to be like it's a full-time job.
Yeah. You'll be just spending your weekend sitting and just looking at the Excel sheets. Yeah,
exactly. Worrying about children's hernias in Oldham or something. It'd be just appalling.
And every consultant will have their priority list. They'll come on, chase everything, isn't it? Like every consultant will have their own list.
Yeah, exactly. And some consultants are a bit more realistic than others, and some are a bit more, let's face it, honest than others. We had one of our consultants at RMCH who was doing some not quite gender reassignments, but gender reassignment for children with congenital adrenal hyperplasia, and saying it was a P2. I was thinking,
oh no, come on. No way you can justify those things.
That has to be done within a month. Unbelievable.
What's it in London? Is it okay? Things are getting better?
In London, things definitely are better. I suppose just like the Neil and Bhaskar are mentioning, basically we don't have like our separate list anymore at UCLH. So basically it's a North Central London thing. So it joins up with Royal Free Barnet. So there is one list. And actually for some reason, I can't remember what the logistics on how that was organized, but they decided that all the operating would be done within UCLH, and they're using the private hospital, the Wellington as well. So consultants from all the other peripherals have to bring their cases to these other places. So and even us, we're moving to the Wellington back and forth as well. So that's the tricky thing, because you're not in your own environment all the time.
I know.
You're sort of judging. Before I used to have this regular Wednesday list all the time, and you just know what you're doing, where you are. Now it's like done almost like 2 to 3 weeks in advance. So you don't know which cases you might have. You don't know where you might be operating, which team. Is just headache. Having said that, they've managed to somehow organize things like equipment moving around. So there haven't been any,
major
situations whereby you suddenly realize that you haven't brought your, microdebrider or something. So, but I think just as like Neil was saying, it's just quite depressing to think ahead, thinking, God, it's going to take a minimum of a year longer to get past this. And to get to kind of our normal timetables maybe. And
good evening, Dr. Herman. Dr. Jayant here.
Oh yeah.
Hi Jayant, how are you?
Fine. Vanakkam.
Vanakkam. Hi Bhaskar.
Hello. Hi.
Hi, how are
Hello,
you?
sir. How are you? I'm fine. How are you?
Good. Hi, I'm okay. How's it done in UK?
Oh, things are getting better slowly, but we're just discussing about our waiting list and getting back to our elective surgeries.
Okay, yeah.
That seems to be a bit of a nightmare actually at the moment.
Yes, of course.
But slowly getting better.
Yes.
Slowly getting better. Yeah.
And
I think the number of cases increasing in India, I believe.
Yes.
Yeah.
Very much so.
Mumbai.
Okay. That's
Mumbai
scary,
is
isn't
more.
it?
Very scary because we don't know who's infected and who's not infected.
That's the thing, isn't it? Yeah. Most people might be just don't have symptoms and just walking around, and
he may be spreader.
Yes, yeah.
But I think we have to go ahead and do things. That's it.
Yeah.
Yeah, do things when you're healthy.
Yeah. How's the vaccination going?
Going on.
Vaccination.
Yeah.
Okay. I think there's a lot of hesitance, isn't it? Like just taking the vaccine, even among the healthcare workers. That's quite surprising.
Especially with the reports in the media because of AstraZeneca.
I know. I think the media just playing a spoil sport, I think.
Yeah.
Dr. Ring, do you want to check your presentation? Hello. Yeah. Your mic is muted, Doctor. Yeah.
All right, now it's on. Okay.
Hello, Dr. Herman.
Hello.
Would you like to check your presentation?
Should I take it? Should I present it now?
No, you check the presentation whether it's working or not.
Yeah. Okay. Wait a minute. Yeah, you're right. I want to. Here it is. Okay, surgery that basics. Goodness, it's good to check it now instead of when some people are waiting.
Yeah, it is better to check right now.
Mm-hmm. I don't know why it doesn't show me my.
Can you see a share screen? Just
Yeah,
at the
no.
bottom of it?
On the share screen, you see, I would like to have this screen, but it doesn't share. It does not share. Oh, here it is. Yeah. All right.
Oh, it's right.
That's
yeah.
You want to introduce or you want someone to introduce? Yeah.
That's it.
Yeah. Then after that, Anbu will be doing. Next is Bhaskar.
That's it.
Always on your video. That will be better.
Do you have any videos that you want to check, Dr. Herman?
I have some. Let us see. Yeah, here is the video. Can you see it?
No, we could just see only the slides.
No, on the right side there is a. All right. I'm wondering.
I think if you could just share your slides first, then.
Oh goodness. I don't know. Everything happens the first time.
It's always a better. You can just double click one of those slides and then.
Bhaskar, I think he has shared this desktop. He has to go to share the presentation after opening that.
It doesn't accept it. I want to go. It's in vacuum. No, it doesn't. It does not accept. I don't know.
You can close it again and you can reshare it. Just yeah, you can share again. First,
Yes.
presentation.
You see here, this is it, yeah, and this would be the second.
Yeah.
Yeah. Is that visible for you?
No, Dr. Eman.
That is not visible for you. Goodness.
No.
All right, let's go back. Turn it off.
Don't worry, we got some time, so don't need to.
So,
We could see your desktop screen, I think. This is a desktop.
you can't see that one now?
We can see your desktop.
Yeah, but that should be the presentation. And this is the video.
Okay, we are not able to see that.
Bloody hell.
Can you re-log in? Otherwise,
Yeah, if you can,
I
close and restart again, maybe.
I will stop. I get out and get in again.
yes.
Yeah, that might be easy.
All right.
Hi, Helen. Sorry,
Hi.
Bhaskaran. Yeah, sorry, I don't think we met.
Hi, Bhaskaran. Good to meet you. Yeah.
Yeah, nice to meet you. You okay?
Yeah, not too bad. Not too bad. Just as you know, it's like just juggling so many things as we were.
Yes. Yeah. Are you back in? Are you still doing P2s or just getting back to some elective lists now?
Yeah, I think it's RNT is it's a little bit varied, and mainly it's all P2s, but our otologists were up and running much faster than us rhinologists, simply because they had more P1s, P2s, cholesteatoma. So I think rhinology certainly was
I know
down the list. Yeah, so things like septorhinoplasty, did not done any of them actually, and fezzes, a few fezzes, but they have to have sort of a good reason. But actually, so yeah, we sort of seem to.
The Royal College of Surgeons guidelines about prioritization basically put all rhinology in one lump in P4, didn't it?
It doesn't really help us. Yeah.
Herman, do you have any videos to check at all in this?
And the bummer is, as a rhinologist, we got stuck doing trachees during that first lockdown because actually, while others, because we were the more redundant types, I thought, this is. They ended up kind of making trachea.
Trachea specialist, yeah.
Yeah, it wasn't fun. I haven't done those in years, and
yeah, I know.
And these COVID trachees weren't fun.
No, not at all.
Sorry to interrupt you. Can you see the
slides? Yes, we can see the slides.
You can see the slide now. Let's.
Any video you want to check?
Yes, check the video. Yeah.
It's fine. The slides are fine.
Yeah. Okay. Can you now? That's a video.
Yes, it's fine.
Fine?
Yeah,
Oh goodness.
that's absolutely fine.
Yeah. Okay. Thank you very much.
So,
I don't know what was the reason that it didn't work, because it's the first time. Because Zoom is really easy to handle normally.
I know. Yeah.
Okay.
So we got 2 more minutes to start, is it?
Yeah. I have this presentation and the tips and tricks for a successful outcome in surgical orthoplasty.
Excellent.
All right. So I better leave it now.
How is the situation in Austria? Is it you are in Vienna? How is the situation in Austria?
The situation in Austria is cold. In the morning it's -4 degrees, so that's really chilly.
Okay.
And during the daytime it's much nicer. It's about a little bit 5+. So you cannot compare it with India. It's more like
No way.
the freezer is about the temperature we have here in our surroundings. We have still snow there outside. Let's have a look. Yeah, you see, when you look out through the window, you can see
Oh, yes.
the whitish thing is the snow.
Okay.
Behind there.
Yeah, we could see that.
Far behind, yeah. Well, so it's
at least it's dry and bright.
Yes, it's dry. Sometimes a little bit snow, but spring is coming. It's getting warm. Birds are singing, so everything is fine now.
Yeah, I think we can start.
Yeah, we can start. No.
Well, let's see.
Yeah, we are streaming YouTube live. So,
you tell me if you can see it.
Yeah, just one sec. I'll just.
Yeah, we can see.
Good evening, and on behalf of Isfaro, Indian Society for Facial Trauma, Aesthetic and Reconstructive Surgery of Photoindustry, we welcome you all to the third session on our aesthetic surgery webinar series. So far, we have successfully completed facial trauma, reconstructive, rhinoplasty, craniofacial, and aesthetic webinar series with tremendous response. Today, we are happy to have most prominent and distinguished persons in the field of facial plastic surgery as our speaker. We have Dr. Hermann Roing from Austria, who is going to talk on non-surgical otoplasty in newborn and surgical otoplasty. Then we have Mr. S. Alam Hannam for the otoplasty earflow technique, and third talk will be on pinna or ear reconstruction by Mr. Neil Batman. Over to Jerry Thomas for introduction of the first speaker.
Hello, good evening to everyone. It's an honor to introduce Dr. Hermann Rondig. He's a consultant ENT surgeon at the Public Hospital of Spittel an der Drau. After completing his studies of medicine at the University of Graz, he went on to obtain a degree in otolaryngology in Leuven. He is an Austrian delegate of the EFPS and a member of the Austrian Academy of Cosmetic Surgery. Furthermore, Dr. Rondig underwent advanced specialist training as a clinical fellow in facial plastic and cosmetic surgery from renowned centers in Switzerland, Germany, USA, and South Africa. Additionally, he has published a soft technique for otoplasty and has written several chapters in a textbook about otoplasty. Dr. Rondig works at his private practice as well as an ENT consultant at the hospital Spittel an der Drau. His main focus and surgical specialties as an ENT include rhinoplasty, otoplasty, and blepharoplasty. Lectures have been presented in Europe, South Africa, USA, India, and China, with surgical demonstrations in Austria, Germany, Norway, South Africa, and China, and he has several publications to his name. Over to you, Dr. Hermann Rondig.
So thank you very much for this famous introduction. I'm a normal human being and I'm interested in plastic surgery. And this is one reason why I'm caring about babies, because I think there's nobody in the world who does more than 3,400 operated ears on cosmetic reason than me. I mean, we've discussed in the European Academy of Facial Plastic Surgery. So the advantage is that auriculoplasty is funded by the NHS, the National Health Service in Austria. That's the reason why I can do so many children's ears and adults' ears too. Well, my topic now is the non-surgical otoplasty newborn babies. The background is that when a baby is born, you have a very elastic auricular cartilage. The auricular cartilage is made of elastic fibers, and it develops from the, let's say, from the first few weeks when you look like this worm from the first and second auricular branch. And there on the first auricular branch, there are 3 hillocks, and on the second, also 3 hillocks, and they are melting together, you see, at 49 days after pregnancy. The melting of the 2 auricular branches are looking like this. Number 7 is the auricular canal, the auditory canal. And look at this one in the 3rd month of gestation. It's amazing how the auricle is already looking like, but it looks a little bit strange, and I'll show you a picture later on. Now, for instance, at this young girl, one could see the remnant hillocks when she was delivered with cup ear deformity, like you can see in the lateral view. One of the most common questions on behalf of babies is, can you correct babies' ears at all? The question is yes, of course. And the second is, what is the best time to do this, to correct babies' ears? It's right after birth, and there is no discussion. There are so many papers about this. They all are in common that you have to start very early. The best day is right after delivery. Of course, there are bigger problems right after birth. If the baby is healthy and so on, if breathing is normal, the skin has a normal look. But if everything is fine, also take care of the auricles. Now there are so many, not so many, but there are some techniques presented how you can correct this baby's ears. Mine is very traditional. I use taping. I show you how to do this. This is a short video, but the number of references is much longer. You see there's a underdeveloped antihelix. You only need to tape the helical rim, and now immediately afterwards you see that the antihelix is looking normal in a C-shaped way. And the second, the lobule is still protruding, so you have to have another tape. I use like a sound strip. This is a medical tape, and it stays for at least 2 weeks. And this like a sound strip, you can cut in the middle, make it shorter. Cut it here. You can remove it with medical benzene. And I don't want to bother you with all the references. They go a few minutes. So it is no discussion, it works. But when the baby gets some of the tape loose, then you have to remove it, and you need medical benzene or alcohol just to get the glue off. And this is the taping, once again, like a sand strip. You can use some other very, very cheap tools to get a good access to this baby's ears. Here you see a convex concavity. I'll show you later on how you do. Of course, business is great, and there is an American company, it's called Earwell. They presented, or I had to buy one of her baskets with the possibility to change a deformity of one ear of one baby only. And that costs about 600 euro. And this is a lot for young families. So I decided to continue with taping. That costs only a little bit of brain and nothing more. But the question is, do the protruding ears always show at birth? Normally they do, but sometimes they do not. You see, this baby was born with very flat ears, even after 2 months. And after the 3rd month, this is very common, after the 3rd month of age, the ears protrude more and more. And when she was 6 years, she had very strong protruding ears. Now the question is, what kind of deformities can you easily correct? The main deformity, as I showed you in the video, is the underdeveloped antihelix, like you can see here. The baby was taped for 3 weeks, and this is the result when the baby was 9 months old. Show you another example. At the day of birth, it was looking like this: strong protruding lobule and the shortening of the antihelix, taped like this. After 1 month and 2 years later, was looking like that. You see the underdeveloped superior crus showing off, but well, you can correct it later on. Once again, I show you this picture, how the helical rim turns in and makes the sumba. Look at this structure. When you see here, when the helical rim comes in here and turns into the sumba, this is also a convex instead of concave. A convex, yeah, instead of a concave concavity. You can change this very easily with a very little effort to get this result. This is the same baby with this little plug. How can you make this plug? You know the silicon, how to make an ear plug, or if you make an ear mold for getting a hearing aid, you make a mold, and this is the auditory canal, and this is the groove of the convexity of the concave cavity. Everything you have to do is just to fill up this convexity to make it flat, and it pushes in the convexity. Show you an example. Right after birth, it was looking like this, strong convexity. After 1 month of treatment, looked like this. The upper third is not really well developed, and it turned at the age of 5, and the parents didn't, or they didn't care so well. They didn't come earlier, so there's still an underdeveloped antihelix and a little cupping of the upper third. The same with the left ear, but that one stayed. This is the same baby. What else do you have in baby's ears? You can have this auricular adnexa. Everything you need to do is just take a very thin, let's say 5/0 suture, but you must not pinch the baby, only you make a knot around it and make it very close to the skin. Then this adnexa becomes dry and falls off. And at the age of 4 years, it looks like this. It's hardly visible. You can also do non-surgical otoplasty by remote control. I tell you, recently I got a WhatsApp from a friend far away that his friend's baby was looking like this, and he was asking for advice. I made this drawing on the computer. Here should be the scaphoid groove, and he should roll it up. I also used my wife's ear to make a sample and sent this picture. This is the feedback I got, stereo strips. But after 3 weeks, the result was like this, without doing anything, only showing how it should look like. Of course, you have to have skilled and have some practice in operating, because sometimes when you have a microtia like this, it is a big problem. The parents were recommended to wait until the boy is 10 years old, then this auricle will be cut off and replaced by a new or ear reconstruction with rib cartilage and so on. I said, let's try, maybe we can do anything else. This was the result after taping. It is not really beautiful. That was the situation when it was 5 years old. This was the intraoperative situs. It also was not really a helpful situation for getting a good result, but still it was possible because there was ear cartilage. This is the main thing. There was ear cartilage available and I could make this ear out of it. You see, the antitragus in the beginning was up here and I had to trim it to make it come down to the normal place. Show you another girl. She was born with a lopping, not cupping of, well, I can say cupping of the upper third like this. This was her with the age, you can see here. And this is her later on. And it looks rather normal. And if she wants to have surgery, she can do it later, but it's much easier to set back ears like this than ears like you can see down here. So don't forget, there are two strips of easy taping that can change the life of a baby. And once again, I show you the video only to remind you of how you can do it. There's a strongly underdeveloped antihelix. You only tape the helical rim to the mastoid and take care that the baby is fed, breastfed before, so that is full and doesn't cry or just defend itself. This is one tape from the upper third down to the mastoid, and the second one comes from the lobule to the mastoid. This is the V-shaped taping that's really not so difficult. So what I want you to do is that you use your acquired knowledge and tell your patients about this, especially the female patients, and I thank you for your attention. And I would like to ask, should I continue with the second second presentation?
Yes, we can go ahead with the second presentation.
These are the tips and tricks. If you have missed this situation of taping a baby's ears, then you have to be surgical. Again, I don't have any conflicts. And I have some tips. You may look here at the number. The first tip is, if someone tells you otoplasty is easy, do not believe. The only thing is that, for instance, if you want to think about antihelix plasty and you feel comfortable with the result like this, then I recommend you just lean back, take a cup of coffee and turn off the computer now for this presentation. It's not worthwhile because I will make you unhappy because I want to show you what is possible at all. So this cartilage cutting technique, however you want to present it, is really not worth calling it cosmetic. The second is the permanent sutures behind the ear. Either they protrude or they show off like this. So antihelix plasty that way is not a good solution. The second is concha reduction.
Dr. Herman, we are not able to hear your voice as well as the presentation. I think got freezed.
Just cut out of thickness and elasticity. And the goal must be to have an operated and natural result. Look at this guy. That's a young gentleman, about 17 years old. And when he turns around, you can see a natural looking auricle, the normal depth of the concrete cavity, the distance from the helical rim to the mastoid is rather symmetric. Everything is elastic. The lateral view shows normal auricular structures. Now, when you look at this was the boy 15 years before, when he was 5 years old. So you see, this is possible, and this is what I'm going to present to you today. Now, the advantages of this presented technique is that I don't use antibiotics. Wherever I go in the world, they all say, yes, we need antibiotics, at least a single shot, but it's so dangerous. Actually, I disinfect very carefully and I do not use antibiotics if not needed. And I have used it with this 3,400 operated ears, let's say about 2 times only in the very beginning when I made some mistakes in disinfecting. I don't use permanent sutures because you are not born with permanent sutures in oracles, so you don't need them. And I'm creating hardly visible scars. I will show you later on. And this technique is safe to the cartilage. It's less invasive than many other techniques that are presented all over the world. And what is also interesting, refinements are possible, let's say 1 month to 6 weeks post-operatively. When I start doing this technique, I always start with anti-helix plasty first, because when the anti-helix is set properly, you can estimate how much the concha has to be reduced. Second, I do the preserving concha reduction, similar like preserving rhinoplasty. I preserve conchal cartilage in the concha and I save it for maybe you need it later on. The third stage is then the lobioplasty, and the fourth is that you suture the superior crus. I use the PDS for the cartilage and rapid Vicryl for skin closure. Now, one of the main differences, what I do is that I do the draping so that I can see the whole face. I disinfect this area. I do not touch the nose and the ears, the eyes, but if you disinfect this area, it is enough. I have no infection up to now. The next step is, if you want a smooth technique, you have to, if you want a smooth anti-helix, you have to have a smooth technique. And this smooth technique is now in this presented filing technique. You have to access in the scaphoid groove. Next step is that I loosen the soft tissue from behind the anti-helix. Next step is to get access, to get subperiochondrious access. You see the white cartilage underneath. Then I undermine the anti-helix as much as needed. In this case, it goes very down to the place where the helical tail derives. Then I take the diamond-coated file. You can get it from Storz. You can say the auricular cartilage file. I do the C-shaped filing. Of course, the real filing takes longer than you can see here on the video. For demonstrational reason, I stop the video then. Now, to compare the difference before filing and after filing, you see there is elasticity on the upper picture and no elasticity, or the elasticity is at least strongly gone on the lower picture. You see, the situation of the anti-helix remains very stable. Show you another picture of a different auricle. Here the elasticity is very strong, like a spring. See, it jumps back so easily. After filing, it doesn't really jump back. It comes up a little bit. And also you see here the inferior crus, there's a big gap. Here the inferior crus is already corrected. And I'm the first who has published a paper about the correction of the inferior crus. You will see it. In case there is a underdeveloped inferior crus, you have to address it. It was already published in 2016. You prolong the incision from the scaphoid groove, then you subtunnel along the inferior crus. You go down to the concrete cavity. You see where the tip of the scissors goes. So when you cut this inferior crus, and this is the only structure, anatomical structure in the auricle, that has a sharp edge. Everything else has a smooth edge. And so the edge is only visible here in along the inferior crus. That's normal. You trim that cartilage because that's abundant. And now you see the gap is gone, like here. So next step is to show you the difference, what happens if you do not address the inferior crus. This is the protruding auricle. After infiltration, you see an underdeveloped inferior crus, superior crus. If you address only the superior crus, like it is usually done in the suture techniques, and you neglect the inferior crus, it doesn't look like a normal looking ear. You see, something is missing here. Now look, if you address the inferior crus, isn't that a big difference between number 2 and number 3? And after skin closure, you compare this one to number 4. I think it's a big difference. Show you an 11-year post-operative result. On the here, that was the lady 11 years before. Rather symmetric, very elastic cartilage. You can't see any scar, a normal looking antihelix. Because of the filing, you get a normal looking structure. The overdeveloped concave cavity, I will go quickly through it. I know the time is running. I do the preserving concave cavity. The key is that I reduce the concave, the protruding concave cavity. Here is the postauricular muscle, and this is the pocket where I'm hiding this muscle after scoring. Of course, I have to take off some skin, a very, very thin or narrow strip of skin. Then I make the pocket. It's important to do it in the proper direction towards the mastoid and not towards the auricular canal. You can see here you can see the postauricular muscle. That's a very important landmark. You always go behind, posterior to that postauricular muscle. The blood supply always goes interiorly. And then I incise the concave cartilage. I will skip over it, make it faster. And then I subtunnel the anterior side of this medial concave cartilage. Then you have to release the anterior side of this concave cartilage all around. In this case, that was not a very big hypertrophic concave cavity, so there is not a big concave cartilage to have to be set back. After scoring, this auricular cartilage becomes flat. Then you put it or hide it in the pocket so that it does not pop up. Otherwise, it would show off behind the ear. It wouldn't be a good result. After that, I use 2 PDS sutures to set back the lateral concave cartilage. When you suture it, you can see if it is set back enough. In this case, it was not enough, so I decided to redo it, to open it, and because it is much safer to start with an undercorrection of the concave cartilage than to overcorrect it. It's impossible to do the rebuilding of the concave cartilage. So you undermine the lateral part and do the incision. Once again, you reduce a small strip of cartilage and then you set it back. You see, incise a little bit, avoid lowering the Simba concave. This is this area here. Then otherwise you will have a very, very flat look of the Simba, so you have to avoid it. Cut out of this, like you see here. Then you do the first mattress suture and you see the setback is much better than it was before. Next, a second suture and then skin closure, and that's done. That's the end of concho cartilage reduction. I do a running suture, and you see in this grease, it's very natural and it is not visible afterwards. The postoperative result for concho cavity, you see this strong hypertrophic concho cavity. It's rather asymmetric because sometimes the skull is asymmetric, but the front view is so important. Now look at this guy, you will see him later from the front side. This was in 4 years postoperative. You see the ears are elastic. You can't see permanent sutures. It's only working on the cartilage and setback of the concho cavity. And the protruding globule is a very challenging part, only for demonstration. I'm marking the lobule so that you can see where you can expect it. The next step is to make an oval-sized excision of the skin. Then you address the medial part of the helical tail and subtunnel it and go to the lobule. You see here the suture of the concho reduction. Everything is fine, and this is the very last step that you do in otoplasty. Next step is that you soften the cartilage with step incisions, irregular. I do not interrupt it. They are only half of the width interruption. Next is the suture. This is a subcutaneous suture that makes a turnover of the helical tail and the lobule, and you will see how natural the look will be after that. And this is not a very big effort, as you see. Of course, you know some skills. You have to be aware that you only get a good result if there is the right vector of the suture pulling. Now I'll open it to show you from the lateral view. Now look here in the lateral view, when you pull it, you can see how it pulls down. And show you another auricular helical tail setback. For me, that's a natural look of the lobule, and there's not very much scarring behind. You have to check the symmetry of the auricle. This is why I do the draping as you saw it in the beginning. Only when at the very end I fix the superior crus with the PDS. The bandage is left for 1 week. After a week, you get the bandage off and use a headband for 2 weeks, day and night. Of course, you take it off for washing your hair, and after a week, you can wash your hair without any problems. Beware of under and overcorrection. There's always a help. If there is a problem, you tell me in time, but I want to ask you not to do the procedure just from seeing this video. Technique is a tool, and it depends on how you use it. What else can you do with this technique? If you have enough practice, only then you can just get some basics. At this video I have in YouTube. Type in YouTube Raunig otoplasty, and then you get access to that video. For instance, you can address cup ears type 1. This is not in the video now. Cup ear type 1, you have to have a special incision in the scaphoid groove. And after that, you compare this auricle with that one. It's looking normal. Or cup ear type 2. This is only one patient, very strange one. Remember this C shape, what I showed you in the baby's ears, in the development of the 3rd month. It was challenging, but I was happy to get a result like this. This was 4 years post-operative. This was the pre-operative situation. another example before and after. So 6 years post-op, I think this is a long-term result. And once again, to choose a suitable technique is your choice. It can make your life easier. And I say thank you to attention. And if you're going to make an autoplasty course, I would be pleased if the politics allow traveling again. I'm already vaccinated, but I still have to wear a mask, and I don't know if I'm allowed to travel still. So this is the place where I live. Here in this place, we still have snow. I took the photo yesterday. So if you feel hot, remember we are freezing here in Austria. Thank you for attention. Well, that's it.
Thank you. Thank you. It was an excellent presentation. And I really enjoyed that. Can we take the questions in last, or do you want it right now?
Pardon?
Can we take your questions last, or you wanted the questions to be asked right now?
Yeah, you can ask whatever you like. If there are questions.
Normally, we ask the questions at the end of the session, so it will be
okay.
Is it okay
No
to
problem. Ask me at the end of the session. I will be ready for you. I will listen to the next speakers, of course, with pleasure.
I welcome Mr. Alvin. Alvin, yeah. Good evening. Can we go to the next?
Good evening, all. Then the second topic is on otoplasty, earfold technique by Mr. S. Alam Hannan. Mr. S. Alam Hannan is a consultant otorhinolaryngologist, head and neck surgeon from Royal National Throat, Nose and Ear Hospital, UCLH, and Royal Free NHS Foundation Trust. After qualifying from King's College London, Mr. Hannan remained in the capital to pursue postgraduate training in otorhinolaryngology and head and neck surgery. In 2009, he was appointed as a consultant staff at the prestigious Royal National Throat, Nose and Ear Hospital, in the UK's largest ENT service, recognized internationally as a center of excellence. And he delivers a full general elective and emergency ENT service for adults and children, and has a subspecialist interest in facial plastic surgery, focusing on rhinoplasty and otoplasty. Earfold was born at Royal Free Hospital, and Mr. Hannan joined the team in 2014. And he has since amassed huge experience in the technique, and thus regularly trains other surgeons in UK and Europe. Over to you, sir.
Okay, thank you very much, Andy. It was a very kind introduction. I'll just share my screen. Bring up the desktop where it is. Great, excellent. Is that visible to everyone?
Yes.
Yes. Yes.
Sorry. Yeah. So you never really know when you're doing this. Just see it yourself. So that's great. Well, thanks very much, Dr. Jaina, for asking me to present the earfold technique at this aesthetic surgery series. So this is basically a way of doing otoplasty. I think one thing that Herman said earlier is exactly right. Otoplasty is not easy. And the key thing about otoplasty I've found is like there's a number of ways to do the procedure, what you're comfortable with, and also what you can do to also offer the patient. So it's about having lots of techniques at your disposal, which you can therefore adapt and offer to a patient as necessary. So I'm going to specifically talk about the earfold technique though. So the disclosure I have is that I've been recruited by Allergan over the years to actually train surgeons in using this technique. but otherwise all these views just are mine. And I'll talk about my own personal experience and how with often a new technique, there's often an enthusiasm at the beginning, and then you sort of draw back and you find a level for it and a use for it going forward. So like I said, I'll relay my personal experience with this. So, what's a normal ear? There's no such thing as a normal ear. It's what the patient perceives. But in terms of ear prominence, it's usually a distance of more than 20 millimeters of the helicomastal distance is often seen as prominent. There's many causes of prominent ears, but these are the main areas. And again, as Herman had mentioned earlier, but most of the problem appears to be from an obtuse antihelix. About 80% of the time, at least, one has to do something to the antihelix. At least half the time, the contral bowl is also quite deep. And then you have prominent lobes as well. Often there's a combination of all of these sort of situations, but by far and away, the most common problem that gives rise to a prominent ear is an absent or obtuse antihelix. And this is where ear folds it can be offered if that's the main problem. So the aims of otoplasty, as we know, particularly with the obtuse antihelix, is to create a fold where it's either absent or obtuse, and there's many options. Generally, they can be divided into suture-based techniques, or cartilage sculpting techniques, or combined techniques as a whole. And I think, as Herman says, when one starts doing this operation, which he quite rightly said is not easy, you develop your own technique, you develop your own style of doing this, what you're comfortable doing, what works well in your hands. So I personally, before earfold, I never did cartilage sculpting techniques. I'd seen it done a few times as a trainee, and it wasn't comfortable with it. I saw complications from that as well. There's perichondritis, infections, and therefore cartilage deformities afterwards. So it's something that I've never done thereafter. And then basically suture-based techniques, which I've kind of tended to basically more do. I tend to use permanent sutures, Ticron in particular, but there are problems with that as well. But often there's a combination. Now, complications of otoplasty we're all aware of, but dividing them into the two main groups of surgeries that one has. With cartilage incising or sculpting techniques, the issue tends to be problems with the cartilage, and one can cause deformities, sort of skin necrosis, perichondritis issues that can result in kind of quite nasty complications down the line, again, which is why I've avoided that generally. Suture techniques, although they may not have those complications, but the chance of recurrence, as you can see in these series here, much higher. Suture extrusions, although you can replace sutures, but not without their problems. So this is where earfolds came into being. So Norbert Kang is a consultant plastic surgeon at the Royal Free Hospital, where I used to have an ENT list, sort of 2013, around that sort of time. And it's one of these things about kind of actually operating with colleagues and coffee room conversations. I mean, we were discussing with Neil earlier how COVID has not allowed us to meet. One of the things in coming to talks is kind of what the learning often is from the questions afterwards or meeting over coffee. So this is how I came across Earfold. It was just over a coffee, literally in the theatre suite with Norbert Kang, who basically was kind of on his laptop, putting some data in about sort of this Earfold technique that he'd been developing up to that point, and that then thereafter I just got involved with the team and the initial research that this involved. So the reason why he developed it, because he basically wanted to make otoplasty more simple, avoid the need for general anesthesia, making the operation a quicker operation, an easier operation in many ways to do, and therefore basically he. Next slide, actually. Yes, here we are. He basically developed this idea. So back in 2002, this is where it all started, actually in his garage, as many good ideas, I suppose, start in people's garages. So you can see there in that diagram that he's used a coat hanger, bent it into shape, created this kind of introduce a device to basically introduce a metal implant that would be put onto the cartilage. So this was the idea. Eventually, after kind of 5 to 6 years of kind of research and development, it produced the implant that you see on that side. And again, there's a lesson into kind of how long it takes to kind of get any good ideas out, because it took literally 12 years to get from his garage to the actual implant. You have to go through kind of various engineering approvals, animal studies, ethics approval for that, then an ethics approval of human trials. The human trial has to have like a 3-year follow-up, so it takes ages to get out there. But you just have to persevere. I think as I found, Norbert, he can't have been the first person who maybe thought of this, but it's the one person who's basically pushed it through. Now, what's the rationale behind the earfold technique? Well, basically the rationale in developing this is basically to provide a quick technique, a technique with a predictable outcome, which is the most important thing, I think, from my perspective. A technique that has reduced post-operative complications compared to what we've just talked about earlier with kind of sculpting techniques or suture techniques. A technique that has a quick recovery and a return to work, no head bandages or any kind of aftercare. Patients actually should be able to go back to work that afternoon if it was done in the morning, for example. Reversible effects, meaning if there was kind of an issue, you could actually just take the implant out, you just back to square one. To create essentially an office-based procedure, but being done in a treatment room as opposed to a theatre suite, although I'll come back to that as well. And also for this latent group of patients who basically, in their minds, wish to avoid standard otoplasty or standard surgery as far as they see. They want to avoid a general anesthetic. They want to avoid all the downtime that's associated with surgery. So basically, they basically almost vote with their feet, trying to look for a procedure that actually looks to them quite straightforward to do and to have done to them. And is suitable for anyone over the age of 7 years old, as long as they can tolerate a local anesthetic. So the earfold system is this 3-part system. There's an implant, as you can see there, which has these sharp tines, not sharp enough to kind of draw blood or anything, but sharp tines enough to grip the cartilage so the implant doesn't move under the skin. There's the earfold introducer, which is an ergonomic device to introduce it. I can talk more about that. And I think actually this earfold positioner, which allows the predictable outcome, this is the most important thing for me. And again, I'll describe this further. But the position is exactly the same material and as the actual implant itself, just doesn't have those sharp tines, because this is what one uses over the skin to mimic where you would want the implant to be. So it gives you that guidance. So I'll mention that. In terms of characteristics of the earfold, you can see here it's compared to a £1 coin. So I didn't have kind of Indian or Austrian currency to show, but it's a small device. As you can see, it's kind of 15 millimeters by 5 millimeters in its rectangular diameter, but it's only 0.15 millimeters thin. It's only 0.068 grams. It's plated with 24 karat gold, partly because nitinol, nickel titanium alloy, is like a gunmetal grey. So under fair skin, one can potentially see a shadow. So the gold plating helps to camouflage that. Also, gold being a further, quite an inert material. The thing about nitinol, why that was chosen, it's engineered to a predetermined shape. So the implant goes in flat, but it's always, once it's released, goes into the same standard shape. So nitinol has a memory. Nitinol is also super elastic. No matter how many times you unbend it, it always goes back to its same shape. So it's super elastic, and they're also fatigue resistant. So you can keep bending it, doesn't snap. So those are the implant characteristics. Nitinol is also tried and tested in the body. It's used in orthopedic prosthesis, in metallic heart valves. So very safe to use in that regard as well. The earfold introducer is an ergonomic system, easy to use. It's a disposable piece of kit. So each implant, after the earfold introducer use, it comes with the implant. You throw it away thereafter. It has various locking mechanisms and located nipples again that allow you to determine where to put the implant. Again, I'll describe all that in the videos coming through. Now, the pre-fold positioners. This is the bit I'm just going to spend a bit more time on, because this is the most important part of earfold for me. It's basically because what this has allowed, it's allowed one to give control to the patient as to what they want to have done to their ears, how far they want their prominent ear correction to be. So the pre-fold positioner is basically placed over your planned antihelix. So you use a positioner variously. Most of the time you can use one that will give you the right result that the patient wants. Sometimes you might use two. And the key thing with this pre-fold positioning is that as part of the earfold consultation, if a patient has come across earfold, they want to try it out, they can actually wear these pre-fold implants over the skin, and it's taped down with a bit of double-sided tape to kind of give them an idea. They're looking in the mirror as you place them, and they're in charge of what the correction is achieved. There are many times I've put a pre-fold positioner on in the place where I think it suits. The patient's looking in the mirror, and I think that's exactly right. And the patient may say, well, actually, I think I want the ear back a bit further. And then one can actually move the pre-fold up and down that presumed antihelix or further back sometimes to basically essentially just put the ear back a bit further or less. So the patient, as I say, is in control. There are times like when I put it on, it looks good. The patient thinks it looks good, and then one can proceed down the line. But the times when they think actually it's not far enough, I can show them where to put it. And if they sort of have the idea that's how I want it to look, they're looking in 3 dimensions in the mirror, it may not be my aesthetic, but actually it's the patient's choice. But it's what they see is what they get. So that's the most important thing for me. There are other times actually when I've put the pre-fold on and the patient's and it doesn't suit. It creates an antihelix, but there's a little kink that develops. Or maybe I think it's gone too far, or maybe it's not gone far enough. But to my eye, it's not aesthetic. So I'm thinking, well, this isn't right. So therefore, earfold is not going to be for this patient. We will discuss, therefore, other techniques. But actually, a patient surprises me. The patient says, no, I love it. I actually want this. And then you can point out the imperfections that are in your mind. You can say, well, actually, have you seen that kink that develops when the pre-fold is on? The patient sees it and accepts it. So that's the key discussion that I think is so important, because if there are imperfections that they see, they've at least seen it pre-operatively. So when that kink is still there afterwards, once you put the actual earfold in, it's there before. And again, you take photographs before and after, of course. So the patient is the person who's accepted that issue. It's akin to, I suppose, the digital morphing that one does with rhinoplasty sometimes with cosmetic patients. I myself don't do that, but basically it's akin to that. But the better thing is, with the digital morphing, you can't guarantee what you may achieve on a computer, and that's really important to get across to your rhinoplasty patients. But with the pre-fold, because it's not digital morphing, it's actually the actual real device. The only thing that's different with the pre-fold compared to the earfold is that fraction of a millimeter of skin in between. So more or less, what you see is what you get for all intents and purposes. So the pre-fold position is there. That's the key thing for me. One might ask, how can you change the correction? And it's all to do with the position of the implant along a proposed antihelical fold, and sometimes the number of the implants. So if someone has no fold at all, you may want to put one in the superior crus and one further down the proposed antihelix. But usually, I think there's a sweet spot I found with earfold, and most of the time nowadays, I'd say 80% of the time, if I'm doing an earfold technique, I will use just a one earfold. Certainly when I started this back in 2013-14, but I was tended to use 2 more often, it seemed. But I think, like I say, you ease back and you realize what suits most as time has gone on. It's certainly in your hands. So the pre-fold bit is my favorite part of this. It, like I say, takes away kind of patient dissatisfaction because they've actually chosen the outcome. So here's an example of, you can see here, this lady, she's got prominent ears, and she's decided that she would prefer to have 2 implants each side to achieve that correction. So that's the correction she's looking for. She sees this in the mirror beforehand. So when you do this procedure down the line, and in the UK with cosmetic surgery, we have what's called a 2-week cooling off period. So a lot of the time I've kind of put these on, and patients are so desperate to have it done, they say, let's just do it straight away now. And you say, no, They go away and think about it for 2 weeks. They take their own photographs, both with the pre-folds and without the pre-folds. They think about it, and they can only book in more, as long as there's a minimum of 2 weeks to think about it and to change their mind. So it's very important, no matter how keen they may appear to be. So, like I say, the pre-fold positioner, really important part of this. Just to go over the technique at this stage, and basically, I don't know if I have a pointer on this thing. I can't remember. There should be a pointer somewhere. I can't remember how to get the pointer. It doesn't matter. Maybe you can sort of work it out. Excuse me, guys. I'll just excuse me a second while I go backwards. Why it's not going backwards? Let me get back to that. Apologies. Okay, so what happens when they come in for the procedure? Essentially, you do the pre-fold bit again. That's the other thing I should mention. So before you go ahead and do anything else, I've got the photographs from before. So again, I sit them in front of the mirror and I put the pre-folds back exactly where they were before, more than 2 weeks earlier. I make sure that the patient again is looking in the mirror and they're happy with the correction. So they still want to go ahead. Yes, the pre-folds are exactly where they were. That's fine. Then with the pre-folds in position, as you can see on this kind of diagram, you mark where the pre-fold is. So you basically, with a surgical marker pen, just essentially draw around the pre-fold. Very straightforward. Sometimes it's actually the pre-fold indents the skin, so you can actually take it off and actually mark around that. Then you put your local anaesthetic in. We just use Lignospan. Very straightforward. Within a minute, it's worked. And you inject around the region of the implant and a few millimeters all the way around. So then you make your incision, and the incision is only about kind of 8 millimeters max, because remember the width of the implant is only 5, 8 millimeters max in the scaphoid fossa, about at least 2 to 5 millimeters distal from that kind of edge where the implant's going to be. Then we use blunt tip scissors to make a subcutaneous pocket. I know some of my colleagues use subperichondrial pockets, but I still make a subcutaneous pocket. Very easy, just a subcutaneous pocket. The blunt tip scissors just slip into that plane, and you dissect a few millimeters all the way around the edge of where the implant is expected to be. And in particular, it's really important to make sure you've dissected at least 5 millimeters ahead of the most proximal marking, because there has to be a little bit of space for the introducer to go in. So that dissection takes just a minute or so. Then there's this whole thing about needle perforation. So Norbert, when he devised this technique, was very keen about needle perforation and still is keen about needle perforation, similar to what Herman was mentioning about scoring the cartilage and basically breaking down the memory of the cartilage. And so certainly I did this at the beginning, but actually I've stopped doing this now because of the last few years. I've found that the ear fold is so firm and sturdy in achieving its correction. Actually, there's no need to do this. Because the ear folds, as long as the ear fold's in place, it will hold the cartilage in place in the fold that you've created. So I've taken out this step, certainly in my practice. Also, the other thing is by perforating the cartilage, potential risk of infection and things like that. So I just want to keep this as minimal as possible. So I know myself and Greg O'Toole and various others, we've stopped doing needle perforation, although this will be a choice that some people make. Then one puts the introducer in, and as you can see, the distal end, you need a little bit of space at the front there, just for the distal end to go in. There's a locator nipple that gives you the idea as to where the implant has to be, and you can actually see and feel it to some extent as well. So basically, it's quite straightforward. So once the implant's in place, then you pinch the ear with the introducer inside, cartilage in place, everything straightens between thumb and index finger, so the tines grip into the cartilage. And then essentially there's a 3-part maneuver with this introducer. You push down, that releases the distal end of the implant. You push forward, that takes away the kind of proximal end. Then you push the whole introducer forward by a millimeter or 2, just to make sure there's a release either side. So the implant's therefore released, gripped into the cartilage, and then you slip it out, and it sorts itself out. Now there's a little little quick video here, so I'll just show this to explain that because it's much easier.
The earfold introducer is a single-use device for the implantation of earfold. During this video, we will demonstrate how to use this device to correctly and safely deploy the earfold implant into the ear. Following incision of the ear, create a subcutaneous tunnel and then insert the tip of the introducer and align it with the skin markings. It should sit at a 90-degree angle to the planned position of the new anti-helix. The larger dimple on the introducer should be in line with the proximal edge of the desired implant. Once the introducer is in place, using your thumb and index finger, squeeze the tip firmly onto the anterior surface of the cartilage, ensuring the implant is flat and flush against the cartilage. This guarantees the tines on the earfold are engaged correctly before deployment. Not having the implant flush against the cartilage may increase the likelihood of adverse events. Press the green trigger downwards and forwards to release the proximal edge of the implant. You will hear a click as this happens. Next, release your thumb from the trigger and reduce pressure of your thumb and forefinger squeezing the ear. This will allow you to push the whole introducer forwards a few millimeters to disengage the distal edge of the implant. As you push the introducer forwards, you should hear a second click. Each click corresponds with successful release of each edge of the implant from the introducer. Once the implant has been deployed, remove the introducer slowly and dispose of it immediately. Check that all the edges of the earfold are flush with the underlying cartilage before closing the incision with 1 or 2 fine absorbable sutures and dressing with wound closure strips.
Great. And just got a surgical video here, which I'll just quickly go through as well. So essentially, as you can see here, the pre-folds have resulted in those markings. So this is Norbert himself doing a case. He's decided that this particular patient, in fact, needs 2 earfolds. So incisions made in the scaphoid fossa, having injected with lignospan. Literally within a minute of that, that's all nice and numb. And then he gets his blunt tip scissors, which are kiln scissors actually, but and then essentially a subcutaneous pocket under the markings, but also about sort of 3 to 5 millimeters all the way around, just to have enough of a pocket to kind of a little bit give it, but particularly most important exactly at this point, right at the front, where the sort of introducer needs to go. I'll just move forward a bit here as well. And I think, as you can sort of see, this is Norbert again doing his needle perforations, just to kind of reduce the memory of the cartilage. But again, I don't feel the need to do this at all anymore. So that steps out. And once he's done that, and you can see how quick this procedure is. This is actually just all real time. So, you know, you wait a minute after an injection, subcutaneous pocket, 30 seconds to a minute. I don't do the introducing, and then you're ready to put the implant in. And you can see how quick this is. The various located nipples, you know, you can sort of see that from the edge there, that's going to be in the right place. Thumb and forefinger, holding it down, flattening it, push down, push forward, out it comes, and it folds over. And that's it. And then essentially, sutures-wise, we just use a 6-0 vicryl rapide, a single suture just to close that linear incision, the scaphoid fossa, and then a steri strip, and nothing more than that. And then the patient essentially leaves. And I've had patients literally go back to work that afternoon, you know, whatever it might be. Fantastic. Okay. Now, just to show you some sort of results there. So this particular patient, you know, he's decided to have 2 implants on the right and 1 on the left. And you can see from there's the pre-op and there's the post-op. and there's a closer picture here. And this is what I think I should say. After deploying the implant, you've got to make sure must make sure it's kind of nice and flush. Otherwise, the implants can be felt and visible. Therefore, so you can see here, it's very difficult to see the implants. You just might be able to see if you look really carefully on the left-hand picture there. There's a little bulge in the lower part. You can see that one maybe, but otherwise, it's difficult to see the others. Here's another patient who's decided to have only one implant each side. And you can see, when I look at these pictures, actually, if this was my patient, I'd be thinking, is that enough for him? Is that really enough? So therefore, in my mind, earfold's not suitable for him. But actually, it's the patient who decides, you know what, this is a simple thing to have done. This is good enough for me. I want this done. And as long as they know from their pre-fold, this is what it achieves, they go for it. So again, you can see here on the outside, little see there in terms of prominence. And then this lady, she's had asymmetric ears, and she's had this result. Again, when I look at her result, I think ears have gone back too far. But this is what she's chosen. So so they've chosen that result, and it actually is something you can provide in this fashion. And there we are. So in her skin, you can see here, I'd say on the right-hand side, you can see the slight bulges of the implants there. But it's only people who know it's really there. And actually people otherwise don't know they're necessarily there. So the patients remain happy thereafter. Now, there have been kind of a number of studies that have kind of happened over the last few years. The ones that our group have actually published back in 2018, 403 patients, 1,200 implants themselves, and an overall complication rate of 9.7%, either due to infection where the implant has to be mainly removed, or skin erosion resulting in implant extrusion. In those situations, we essentially remove the implant, let things heal over. There's an option to actually reinsert there afterwards or do another technique. And then at the moment, we're just wrapping up a long-term prospective study that's collected 100 patients prospectively, following them up for 2 years. And actually that closed to recruitment a few years back. And we should be finishing the final 2-year follow-ups this year to kind of publish that as well. So going forward. So conclusions-wise, earfold, an effective technique at correcting ear prominence. What you see is what you get. And I think that's the most important thing for me. There's no other technique in cosmetic surgery as a whole whereby you can sort of more or less surgically guarantee to a patient what you see is what you get. And I think that's a real bonus, especially with the body dysmorphia that often goes with facial plastics. The main effect for earfold is to reform the antihelix. Some of us have been using it to help with deep contour bowls, and I think certainly I did that myself in the early days, but I've certainly ceased doing that. There are definitely better ways to do that, and I think for me, earfold is purely just to correct the antihelix. And it can be used in conjunction with other procedures, but that's also something I've stopped doing. And in the early days, sometimes I'd do an earfold for the antihelix and then a contour bowl reduction separately. But now I think if an earfold doesn't do the job by itself for what the patient wants, then I will do a surgical technique, full stop. I don't mix the techniques anymore personally. So it's an easy technique to learn, and hence, but there are potential for complications. With implants being left too prominent, giving rise to skin issues or extrusion thereafter. So although it looks easy to do and easy to learn, that's why there's training courses, because actually there is a knack to doing this, as with any kind of surgery. I think, just to reiterate what Herman said at the beginning, otoplasty is not easy, no matter how easy it might look, but it's not easy. So it's the training courses are particularly important. In fact, Allergan insists that people have to be trained, get certified before they start practicing this. And the other thing to say is, well, this is not for anybody to do it. I think there is a tendency that this has made otoplasty easy, and therefore people who don't practice otoplasty may be able to do it, and that's the mistake. The only people who should be doing earfold are people who practice otoplasty, because you have to have other techniques. You have to be able to correct issues. You have to be able to offer patient the full kind of range of techniques. And if earfall doesn't suit, there should be other options. But it's just so it's certainly not for everybody to use. It's only for people who practice otoplasty anyway. And like I say, it's not a replacement for standard otoplasty. It's just an alternative. And I think if one's practicing otoplasty, it's just something worthwhile having. Certainly in my practice, before earfall came along, I did a handful of NHS otoplasties, as all of us experience in the UK. We don't really get those referrals that much nowadays, but just a handful, and even less privately. But since earfall has come along, it's actually patients who demanded it. Certainly when this started at the Royal Free, we had like a waiting list of nearly about sort of 9 months before we could actually do something, because there's only the 4 of us at the Royal Free offering this before Allergan took it on and now introduced it around Europe. And the next stage is meant to be North America, then Asia. So it's been huge, and I think, personally, I've done over 300 of these implants in that period of time, and it's simply because patients want something, and there's this latent group of patients who feel that they want something simple. And what often happens with an earfold consultation, when they've come along, they want to find out what's going on with earfold, see if it suits them. If it turns out during the consultation with the pre-fold it doesn't suit them, then actually they don't want anything further done. They thought, okay, if this had worked, they would have gone for this. But if it doesn't, then actually they'll just leave their ears. So I think that there's this latent group of patients that have come to us. And actually, I should say their age group is interesting as well. They're usually in their 40s or 50s, which surprised me at the beginning, but doesn't surprise me now. It's that group who basically aren't that bothered about their ears. They get through life. They're well-adjusted, got good jobs, married, and all that sort of stuff. But actually, they're at a stage when they've got disposable income and they think, well, I've been sort of bothered by my ears, and actually something simple in their mind has come along for them to give a go with a little downtime. So they go for it if it's suitable, and if it's not, they do something else. Excellent. Now I think that's me done. Yeah, it's 1:40 GMT time. So great. That's I'm going to hang around. Of course, I can take questions at the end as well. So thank you for listening.
Thank you. It was nice and very informative technique. And how much is the cost of the earfold?
Well, in the UK, I mean, basically the implant is quite expensive by itself. So the implant itself, each implant is £512. So if you have 2 implants, then it's your cost of surgery on top of that. So, but the cost of surgery, I mean, actually, we don't at the Royal Free, we didn't downplay it. I mean, because offering this privately, kind of, the surgical fee for putting it in, with and it's just a minor op suite, so it's done in office space. So it doesn't need theatre, doesn't need any sort of this. So that fee is £750 on top of that. So it's but it's up to you what you want to introduce. I know there's one trust in the UK, Luton and Dunstable, the plastic surgeons there. They put a business case for this to their kind of managers, and they managed to get this on the NHS, which is amazing. So they said they can move otoplasty out of theatres. So they've managed to somehow do that. We've not been successful, even my trust, let alone them. So I don't know how they've done that, but that's quite impressive. So so there are cost savings on the ways.
Thank you. We'll take the questions at the end. Bhaskar?
Yes, yeah. So it's my pleasure to introduce my colleague, Mr. Neil Bateman, who is a consultant pediatric ENT surgeon at Royal Manchester Children's Hospital, which is one of the busiest ENT pediatric service in our country. Apart from the general pediatric ENT practice, he's got special interest in airway and ear reconstruction. He's a past honorary secretary of British Association of Pediatric Otolaryngology. He's also a course director for international coblation tonsillectomy. He's a great teacher and a trainer. He's a faculty in many courses and workshops. And to his credit, he's published many articles and written book chapters. I can go on, actually. Yeah. So over to you, Neil. Thank you.
Bhaskar, you're too kind. Thank you so much for asking me. It's a pleasure to be talking today. I'm just going to share my screen. Yes, can everybody see that?
Yes, yeah, we can see.
Fantastic. So yes, thank you so much for asking me to talk. I'm going to talk, as Bhaskar in his very kind introduction said, I'm a pediatric ENT surgeon. working in Manchester in the northwest of England. This is the hospital I work in. It's 10 years old now, and we have a very, very busy, it's the busiest children's hospital in the UK, and we have a very, very busy unit. And as part of my practice, when I moved here, having had an adult practice where I undertook some nasal reconstruction, and having always had an interest in otoplasty, I started doing ear reconstructions, which I found a really, really fascinating part of my practice and something that's incredibly rewarding. My talk today is going to be really focusing on congenital microtia. And so I'm going to talk about ear reconstruction in the context of congenital microtia, because I am by nature and by upbringing a pediatric ENT surgeon rather than a pure reconstructive surgeon. So what I'm going to talk about is a little bit of pinna anatomy, a little bit about classification, and then I really want to focus on assessment, how we manage hearing very briefly, talk a little bit about cosmesis and techniques, and then about the overall approach and how having a multidisciplinary team is really important in these patients. So I think the cosmesis of the ear is really interesting. We never really notice ears unless they're abnormal. I've never heard of anybody being complimented on their exceptionally attractive ears. We only ever notice ears when they are abnormal or noticeable. And I think if you asked a member of the public to draw a nose, they would almost instinctively have most of the sort of key anatomical features of a nose quite easily to hand. But actually, if you ask someone to draw an ear, I think they would really struggle. And I think a lot of ENT surgeons might struggle to come up with the complexities of the pinna that are sort of bread and butter to people who are ear reconstructors and otoplasty surgeons. I think there are aspects of pinna anatomy which don't come naturally to us. Now, I'm just going to see if I can use a pointer. I don't think I can. It's a bit more difficult, isn't it? But I think the key issues, when I really started doing ear reconstruction, I became somewhat obsessed by how pinnas should look, as I think you have to if you're going to do this kind of surgery. And two of the things that really struck me was the relative width of the concha compared to the relative width of the pinna. And the concha actually takes up a significant proportion of the width of the pinna, which is really important when you're thinking about pinna reconstruction. And the other thing that's really important when we're talking about how to reconstruct a pinna is, I think, the importance of the tragus in framing the way that the pinna looks, and also because a lot of the patients that we have not got an external auditory meatus. Having a nice prominent tragus often gives the illusion of a meatus there. Having some height at the point of the tragus just emphasizes the fact that you have some depth where the external auditory meatus should be. So, I think it's really worthwhile just having a really good long think about how the pinna should look and how the proportion should be. And have some examples, especially with the width of the concha of that later on. So, congenital microtia is relatively uncommon. It's about 1 in 10,000 live births, more common in boys. The overwhelming majority are unilateral, and it's said to be more common on the right side. In 90% of them, it's a completely isolated problem, and there are no associated abnormalities. They almost always have a hearing loss because it's very often associated with canal atresia. And because of the embryology of the ear, the inner ear developing from endoderm, from the otic capsule, and the pinna and the external meatus, and the middle ear developing from the branchial arches, they almost always have a normal functioning inner ear. And so the hearing loss is almost always conductive. And they have what you would term a maximal conductive hearing loss. And in terms of classification, we would use this straightforward grade 1 to 4, where grade 1 is a small pinna, but all subunits are present. Grade 2, you have a partially developed ear, but you still have recognizable subunits, and they often have some stenosis, or sometimes they'll have complete atresia. Grade 3, which is the commonest type of microtia that we would end up doing a reconstruction on, is when you have a small cartilage remnant but a lobule present, and they almost always have atresia, and that would be what would be termed a lobular microtia in the Nagata scale. And then grade 4 is complete anosia, which is incredibly uncommon. I don't have a picture of it. I just have a picture of a child who's just got a lobule because it's so rare. And so this would be grade 1. As you can see, there are recognizable subunits, but it's a small ear. And as you get more significant, you'd call that a grade 2. And she has canal atresia, and this is why she has bone-anchored hearing aid. And this is grade 3. Your classic lobular atresia, lobular microtia with clearly canal atresia. And then this is as close as I've got to grade 4 with a canal remnant there and some lobules. You sometimes, or some little cartilaginous remnants there. You sometimes do, what I have seen is almost a canal atresia, but almost a first branchial cleft anomaly, so that you have an external auditory meatus that opens up in the neck and then runs up towards where the middle ear would be. And I've seen more than one child like that. And those canals are very, very often very intimately related to the facial nerve, which is often very, very abnormally positioned in these patients. So in terms of an initial workup, most of these children happily come from a pediatrician and have had a thorough pediatric or neonatal workup. But if they haven't done, then they do need a careful look at from a pediatric point of view and a neonatal point of view. And rather than doing that myself, I'm a big believer in us recognizing what we are trained in doing and recognizing what we do all the time. So I have a very low threshold for calling up a pediatrician and asking them to give them the once over. Essentially, we need to be assessing for associated conditions, and craniofacial microsomia is actually not uncommon in these patients, and very commonly I will see children with some very subtle facial microsomia that has gone undiagnosed and hasn't been given a label of something like Goldenhaar's, but very often they'll just have some very subtle asymmetry of the face. And then there are other syndromes which are far more common, like far more easily recognizable, like Treacher-Collins syndrome, which is of course very, very obvious in the overwhelming majority of those patients. And it's really important to assess the presence of an external auditory meatus and whether it's atretic or whether it's stenotic, because that's an important thing to be aware of. And in terms of hearing, Well, in the UK, these children would come off the normal neonatal hearing screening pathway where they would get otoacoustic emissions, and they just get an immediate referral to audiology services where they would get threshold ABRs, automated brainstem response. Now, what we really want to know is what the bone conduction ABR is on the affected side, because if they are like 99% of children with microtia, that will be normal. In other words, they'll have a normal cochlear function. And what we want to know is what's the hearing like on the unaffected side, because that's clearly an issue in terms of what we need to do with regard to looking after this child holistically and making sure that they're not significantly disadvantaged in terms of speech and language development. Very often, these children come to us in our microtia clinic having had extensive imaging. And I think actually there's almost never a role for imaging at first diagnosis, and imaging has a very, very limited role in general. I think the only real time that we would image patients is if they have a stenotic canal, and the stenotic canal starts to give problems with recurrent infections or discharge, and we start worrying about a canal cholesteatoma. The fact is that it's incredibly uncommon for us to consider middle ear reconstruction in these patients. The hearing is far more reliably and safely rehabilitated with a bone-anchored hearing aid. And you pretty much know that if you've got a grade 3 microtia, for instance, it's highly unlikely that your ossicles are going to be normal. And I'm not sure that knowing how abnormal really justifies the exposure to radiation, the need for a general anaesthetic in a lot of these children to be scanned, and often the delay in referral to someone who's going to sit them down and talk them through what's going on. So while a lot of them come with imaging, I almost never would image them if they came to us without. I think it's worthwhile just thinking about the general approach to this, and I think this is really important. And I think I go on to my trainees about this all the time, and I'm not going to teach you all how to suck eggs in terms of how to speak to patients, but it's really worthwhile just thinking about the terminology when we talk to parents, especially in areas where they are going to have a lot of communication with other families, and there are a lot of Facebook groups and online communities of children with parents and families with microtia, and we recognize that when we see these patients, we're going to be looking after them for a significant period of time, and it's really incredibly easy to have to just sour the whole relationship for good by just a slip of the tongue and a careless use of terminology. So we would always refer to them when talking to parents as children, right? Children with microtia, they're children first, rather than microtia kids. When we're talking to the children, we would never talk to them about their abnormal ear or their bad ear. That is their special ear. And there's going to be a recurring theme through this talk in terms of the importance of involving patients and involving children in decision making, and I think that's absolutely paramount. We would delay doing anything until we can talk to a child specifically about what they want, and we direct parents and patients to the microtia patient groups because they find them incredibly helpful. So in terms of hearing issues, I was always brought up as a trainee, which is becoming a depressingly long time ago now, with a fairly traditional view of a unilateral hearing loss, was that if you were born with a unilateral hearing loss, it actually didn't really make very much difference. You grew up and and everything was fine, and you just got used to the fact you only had one ear. And that's true to a certain extent. There's no doubt that if you've got one good hearing ear and a maximal conductive hearing loss on the other side, you're highly unlikely to be significantly disadvantaged in terms of speech development. You have enough access to sound to develop speech normally. But all that changes when you go to school, and there's no doubt that there are significant potential educational issues with having a unilateral loss, which I guess makes sense. You know, you suddenly go to school, classrooms are acoustically terrible environments. You have to follow instructions over background noise. I don't know, I got wax impaction a few years ago and went swimming, and I basically had a sort of 35 decibel hearing loss in one ear, and I found it incredibly difficult to function. And that made me think about what it must be like having a unilateral hearing loss in a crowded classroom. And so from the States, there are really quite compelling research that shows that if you have a unilateral hearing loss, you have a fairly significant chance of repeating a grade. For those familiar with the US education system, that basically just means failing a year, and a 12 to 41% chance of receiving educational support, which is of course not the same as needing educational support. There may be significant numbers of children who actually need it, who don't get it. So what that should tell us is that having a unilateral hearing loss is a potential significant educational disadvantage. And so we rehabilitate our children's hearing almost exclusively with bone-anchored hearing devices. And I have an otologist that I work very, very closely with, and I'll talk about our MDT. But for children with bilateral microtia, at a very early stage, they will be using a bone-anchored hearing aid on a soft band. There is some debate about whether or not there's a benefit in using a soft band in children who have unilateral loss early on in an attempt to develop neuroplasticity. It's not really backed up with any significant evidence, or it does kind of make sense that you use that. The more you use those auditory pathways, the more they will develop. So it's something that we offer to parents, and some parents will take us up on it. It's difficult to get parents to comply with it, because with using a soft band in a very small child with a unilateral microtia, because they get almost no feedback, they hardly notice any difference. So most children end up starting to use a soft band when they go to school, and then when they are a little bit older, then we start thinking about, do you move to a soft band to a surgical technique, either with a transcutaneous or a percutaneous implant. And of course, it's somewhat more acceptable for girls to have a headband than boys. So it tends to be the boys who want to go to a surgical procedure sooner rather than later. And I'm not going to talk about the pros and cons of trans versus percutaneous implants, but suffice it to say, we have a bone-anchored hearing aid MDT, where we thrash out the pros and cons for each patient individually. A brief word about canal atresia. Surgery to correct atresia is challenging, and while some people report really fabulous results, that their fabulous results are not necessarily repeated across the world, and long-term results are unreliable. My own experience is that you can construct a really lovely wide canal, try and line it with as much skin as you can, and restenosis is really common and discharge is really common. So actually, my view would be that if you are going to have a problem with your ear canal, you are almost better off with an atretic ear canal than a stenotic one, because a lack of an ear canal is not an obstacle to hearing rehabilitation. And if you have atresia, then you're not going to run into problems with canal cholesteatoma and infections and impacted wax. So actually, if we have canal atresia, we leave it alone. So moving on to cosmesis, well, we have three options, and I think it's really important that we talk everybody through all of the options at every stage. And they are to do nothing, they are to use prosthetics, or they are to have some form of autologous reconstruction. It's amazing how often children will opt to do nothing, and it's amazing how often they will be absolutely convinced that they want something doing right up until the point where they have to decide. And I think this kind of, my observation is that children in this situation have a disproportionately high rate of anesthetic room refusals, just because, and I assume it's just because it's a big change. And, you know, while we wait for several years before we think about reconstructing their ears, and even though they for years they've been thinking about this as an obstacle, and, you know, as a hurdle to get over in life, actually it's incredible how often they'll get to 8 or 9 and just say, well, this is my ear and I'm pretty happy with it. And I think actually, you know, from the point of view of a somewhat sort of, I always think that pediatric ENT surgeons are at the sort of hand-wringing liberal end of the surgical spectrum. And I think it's fantastic when you have a 10-year-old boy who says quite confidently to you in the clinic, no, this is fine, this is my ear, because actually what that means is he's very, very happy in his skin, and so I would never be upset by that, however much I love reconstructing ears. So in terms of preoperative considerations, we would never really operate before the age of 9, and that's really about two things. It's about having the psychology right and having a child who is able to make good decisions and know their mind, and also it's, from a purely practical point of view, it's having enough rib cartilage to build a pinner. So that's kind of the minimum age, and I'm really careful to tell them that there is no window of opportunity that closes at any given age. You know, it's actually not uncommon that I will go down the corridor and operate with our adult colleagues and Bhaskar in the future to do an ear reconstruction in an adult, and so it's important that they recognize that there's no pressure to make this decision. The position of the lobule is important, as is knowing about, as considering facial microsomia. It's good to know, do they have a nice mastoid prominence, because you need to know where you're putting the framework, and the hairline. You know, you need to have enough space to get a framework in and not have, and be clear of the hairline. So those are the things that we're thinking about when we're looking at these patients. And in terms of preoperative counselling, it's really vital that a patient can voice their own opinion. I get very, very concerned when I say, do you have any questions? They don't have any questions. And if they have no questions, I start to make excuses and start to say, oh, I'm not sure that floating rib is big enough. Let's see you in 6 months and think about questions, because I think it's really important that they are fully engaged in this. They have to have a full explanation of the options. And what I tell them is, I think it's really important that we are completely honest about the limitations that we can, in terms of what we can build them. So what I in general say is, we can make something that is recognizably an ear. We can make it the same size as the other ear. and we can make it the same shape as the other ear. The limitations are the fine detail of the ear, in that the skin over your reconstructed ear is inevitably somewhat thicker than the skin over the other ear. And the other thing that is really difficult is to get it to adequately protrude. So you've got, you know, 2 talks talking about how to correct protruding ears, and 1 speaker who's going to complain about how difficult it is to get ears to stick out. So the first thing to think about is prosthetics, and here is an example of a prosthetic ear, and I will come to the pros and cons in a little while. But what I tell patients is that actually, from a distance, I have to be honest, a prosthetist can make an ear out of plastic that is far better from a distance than an ear that I can make out of skin and cartilage. And that's just, you know, from a purely practical point of view, that's not living tissue. And they don't have to give any consideration to it staying alive. The disadvantages of prosthetics are that it always feels like plastic. And that can be a major problem for people. They fade, and it's not so much of a problem in someone with paler skin, but if you have someone with darker skin, after a while, that prosthesis will start to become very, very noticeable. And the thing I'd say to people who've got paler skin is, of course, if you get a suntan, your ear won't get a suntan. The biggest disadvantage, I think, apart from patients being concerned about it not being their own flesh and blood, is the fact that in order to put a prosthesis in, you have to remove surgically all of the ear remnants and put bone anchored abutments in, which basically means that once you've done this, there is no way back. You cannot really practically think about doing an autologous reconstruction. Here's another great example of a prosthesis, and this is someone from my predecessor's practice, but actually it looks great. We had an SHO who had an ear prosthesis a little while ago, and to my shame, I didn't notice that he had one for about 6 months, because actually it just looked so good. So in terms of autologous reconstruction, we use a 2-stage procedure. The first stage involves implantation of a framework constructed from rib cartilage, and the second stage involves creation of a post-oral sulcus with a skin graft. I'm going to briefly talk you through the procedure. Clearly, I'm going to be relatively light on surgical detail, because clearly this is not something that you can learn with a 40-minute lecture. But in terms of the basic steps are the site preparation is what I would do first is make an incision such that I can transpose the lobule postero-inferiorly, and then create a small pocket within the lobule. We remove the remnant cartilage and then create a pocket for the framework. And all of the suture lines at this point must be airtight. So what I need to do is, no, I was trying to find a marker, but I can't. Doesn't matter. So what I would do is make an incision across the top of where you want the lobule to be, transpose it backwards, remove these cartilaginous pieces that are creating the remnant pinna, remove this preauricular lesion as well. I save the cartilage from the remnant because it tends to make a really nice tragus, and then create a pocket for the framework, and then go ahead and harvest cartilage. And when we're harvesting cartilage, we harvest the floating rib, which we use for the helix, and also use part of it for the antihelix. I tend to leave perichondrium on the deep surface. We harvest a block of cartilage and leave perichondrium on the deep surface. And partly we do that because it encourages some regrowth of cartilage, but also it's one way of trying to minimize the risk of a pleural tear and a pneumothorax. We check for a pneumothorax with saline before we close it up. We actually harvest quite a lot of costal cartilage in pediatric ENT because we've been using it for laryngeal reconstructions for years. And actually, from my experience of doing this, if you do get a pleural tear, it's actually really straightforward just to close it up with some 4-Vicryl. And you can get the anaesthetist to just inflate the lungs before you put your last stitch in, and it's actually really uncommon that you need to put a chest drain in. You can usually just close the pleura primarily. It tends to be quite painful. This tends to be the worst part of it. I think in general the younger kids tend to bounce back pretty quickly from this, and most of them are only in hospital for 24, 48 hours afterwards. The older kids, we tend to give patient-controlled analgesia as well as a long-acting intercostal block. And this is what it looks like. This is actually pictures of taking rib cartilage for a laryngeal reconstruction, but you can see that you can isolate the rib, you can dissect underneath it. It's a bit like doing a septoplasty underneath it. You can make an incision along the top end, get in the subperichondrial plane, dissect right the way underneath the rib, and then get an instrument that you can cut down onto, lift it up, and leave the perichondrium in place nicely. And then from a point of view of a framework reconstruction, we have a block that forms the majority of the pinna. I use the floating rib and just curl it around the top to make a helix. I shave a portion of the thicker part of the floating rib off, partly to just encourage the floater to bend to make a nice smooth helix, but also to create the antihelix. And I use a bit of tragus to create a bit of remnant cartilage to create tragus. And we wire all this together with steel wire sutures, and we leave a little bit of cartilage banked underneath the chest wound for the second stage. So this is the sort of thing that we make. I tend to use X-ray paper, which is a rapidly dwindling resource in Manchester because we're almost completely electronic. But I have a stash of X-ray film and take a tracing of the other ear, and then we have our block, our floating rib, and a bit of remnant cartilage. And this is one of my earlier efforts when I was operating with my mentor. And just look here at the width of the concha. And I think one of the ways I've refined my technique is by making that the width of the concha greater. When I look at that framework, I kick myself because the concha is not wide enough and the scaphoid fossa is too wide. But that gives you an idea of the floating rib wired onto the block to make a helix, the antihelix in place, a back plate created from an extra bit of cartilage with a bit of remnant cartilage wired on to make a tragus. And here's one that I've done more recently. This is immediately before I put the tragus on. but you can see here that I've actually got a much narrower scaphoid fossa and a much wider concha here, and I think a much more aesthetically pleasing and natural looking framework with that one. So these are the sort of results you can expect to get. I think this surgery is fantastically challenging. I think it's undoubtedly the most difficult and the most frustrating surgery that I do. But these are the sort of results that you can expect to get with autologous reconstruction. And you can see we could have more of a pinna there, more of a tragus there, and slightly less of a tragus there. Sorry, that slide is somewhat out of order. We then move on to a second stage, which we do 6 months later. And that involves making a post-oral incision, elevating the framework, trying to avoid any cartilage exposure. We fashion a pocket on the posterior face of the framework and take the banked cartilage out and just suture that in as a prop to try and get the pinna, the reconstructed pinna, to sit forward, and then put a partial thickness skin graft on the back. One of the ways that we've changed our technique is by avoiding using a head bandage. We just suture some dressings in place for 10 days. After the first stage, we use suction drains for a week. And what we're going to start doing is, once we recommence doing this kind of surgery post-COVID, is I think we're going to experiment with avoiding a head bandage after the first procedure, or at least using it only for a short period of time. Because we've had one patient where just with an ever so slightly tight head bandage, we lost a little bit of skin, which actually healed up quite nicely after a while. But it's not at all uncommon to see just slightly unhappy skin over the framework. And I think we've been overusing head bandages, so we stopped using a head bandage for the second stage, and I think we're going to stop using them for the first. So back to the results here. Yes, so that's the sort of results you can expect to get. I think you'd agree that they are ear-shaped and ear-sized, but not quite as good from a distance as a prosthetic. And here's another one here. You can see here we are lacking a tragus, which does affect the overall appearance of the ear, but she was quite happy with that result. And I think there are pros and cons with prosthesis and reconstruction. Almost all of our patients go for reconstruction rather than prosthesis, and I think there's no doubt if you've got a prosthesis, the surgery is quicker and with less morbidity. You don't have to have a chest scar. The aesthetic result from a distance is, in my view, better, but there are limitations. They fade, they need replacing, they feel like plastic. And the other disadvantages are that once you've had that surgery, there's no way back. You have to have the lobule removed. There is significant skin scarring. We've had a few patients who've come to our microtia clinic who'd had a prosthesis and wanted a reconstruction. They were very disappointed that they weren't given that option at their initial surgery. There is significant abutment site morbidity. Anybody who looks after bone anchored hearing aids will be able to tell you that. And ultimately, it's not the patient's own flesh and blood, which is a problem, and I can understand why. So I think there are two main reasons to have an MDT where everybody where you have all the options. So the first is so that it's important that you're able to offer all the options. I think having a microtia service where you would have to send them out to get reconstruction or send them out to get prosthesis is definitely suboptimal, because there's a chance that they will then make the sort of decision that's the path of least resistance. So I think you need to be able to offer not only reconstruction but also prosthetics, so that you're able to sort of give them all the options without the inconvenience of having to travel to another city for one of them. And the other one that's really important, and we see this all the time, is integrating reconstruction with hearing. It's not at all uncommon that we see kids who've had a bone-anchored hearing aid put in by a really well-meaning ENT, and it's and then referred to us for reconstruction, and the bone-anchored hearing aid is just in entirely the wrong position, and sometimes exactly where you would want to put a framework. And people think they're putting the Baha far back and out of the way, and actually it's exactly where you would want to undermine the skin to put a framework in, or exactly where you'd want the framework to sit. Here's a classic example. It's going to be almost impossible to get to undermine the skin sufficiently to get a framework in there, and somebody has just slapped for some reason, I cannot recall exactly why, but made an incision over the ear, it's exactly where you want to make a pocket to put your framework in, which I think is going to certainly cause me some sleepless nights about the integrity of that skin. So I think it's really important that all of these children are managed within the context of a multidisciplinary team, so that rehabilitating hearing doesn't compromise reconstruction, and so that they have a holistic view of their problems. And so we have a really nicely functioning microtia team in Manchester. I am a reconstructive surgeon and do the ear reconstructions. My colleague Jayana Charney is a consultant ENT surgeon who has been really active in not only helping me with the reconstructions, but she's an implantologist, so is a real expert in hearing rehabilitation. In the clinic room, we also have an audiologist who's able to talk parents through the pros and cons of hearing aids. For surgery, my colleague Ian Bruce comes and harvests the rib, which is fantastic because it means that I can just concentrate on getting on building a framework and doing the reconstructive bits. We have an associated geneticist who has a particular interest in branchial anomalies, which is fantastic, and we have access to psychological support. And we run monthly clinics and monthly all-day operating lists. Hopefully all that will start again soon. Now COVID seems to be calming down a little bit in the UK. And we also have a monthly bone-anchored hearing aid MDT where we discuss all these patients with our audiology colleagues. And all of that leads to integrated decision-making and integrated surgery. And we also have really strong links with our adult services, with Tim Wolford prior to his retirement and Bhaskar moving forwards, so that we can provide a really an ear reconstruction service for people of all ages. So thank you very much. I'm really happy to take questions.
Excellent, Dr. Neil. Excellent. I think you just nailed the importance of having this multidisciplinary meeting. Why, what's the importance of it? Can I just ask one question, Neil? I know we are harvesting quite a bit of a cartilage. Does it leave any chest wall deformity, or or do they, or do they just accept that, or the patients?
Yeah, so I mean, obviously it leaves a scar. It's really uncommon to see a significant chest wall deformity. We see these kids 1, 2, 3 years down the line, and their chests look normal. And I think actually leaving the perichondrium has a lot, has a big role in that. I know that my colleagues down in London will often will sort of morselize some cartilage and and reimplant that, which we're not doing at the moment. But it's pretty uncommon that you'll see a significant chest wall deformity. We do warn them off contact sports for a few months.
Okay.
Just, you know, and I don't have much evidence to support that, but I think we would all feel terrible if someone got a significant sort of lung or liver injury because they got a knock on a rib cage where there was a bit of rib missing. But I think leaving the perichondrium is the key step there.
Yeah. Just one more question. Do you have to ever use temporoparietal flap? You know.
No, I've come close to it with the patient who lost some skin, and I was all set to do a temporoparietal flap, but actually got away with it and sat tight and didn't need to. My concern about it is just interfering with hair and getting some alopecia from an incision up here. So I think it's not something we've had to do, and it's not something that's in our normal, our normal technique. And actually, skin issues over the framework have been pretty uncommon. So I think we've managed to get away with it.
Thanks, Jay.
Thank you.
Any questions, Jay?
Yeah, may I ask a question?
Yeah,
Dr. Neil.
Yeah.
How do you manage the lower hairline?
Oh, really? It's incredibly difficult. Usually, we can get away with it by just making a slightly smaller framework, or asking our plastic surgeons, is there any way that they can sort of do something clever to get rid of the hair? But it's you know, there is not an easy way around it, and I think often you have to just compromise the size of your framework rather than have a hairy ear, if that makes sense.
The incision which you make to put in the cartilage framework, is it always superior to the auricular framework, or in the middle of it, or longitudinal?
In the middle. So I was struggling with that to get a pointer, but what I would do is make an incision. I use the same incision to transpose the lobule. So my incision would go just, across the top of where you want the lobule to be, and then use that incision. And so you're then sliding the framework up into a pocket. And then you just have one incision that goes across the ear, which actually heals up beautifully, and it's often just not noticeable. The only difficulty that you have is getting that completely airtight, so that when you put the suction drains on, the skin just falls onto the framework nicely.
Yeah, thank you.
Pleasure.
Any technique how to learn the framework, how to do a framework, cartilageous framework?
How to learn it?
Yes, special.
Yeah, I think it's every aspect of this type of surgery. I think it's like all reconstructive surgery, isn't it? But every aspect of this is difficult, and making the framework, I think, is a particularly tricky bit. I found just having a mentor and doing cases with my mentor absolutely invaluable. So I don't think that there's any alternative but to find someone who's doing these and do a bunch of cases with them. I was incredibly lucky. I think I was incredibly lucky that I arrived in Manchester at the time when my colleague was thinking, I need someone to take over this service, but I'm happy to spend the next 2 years doing joint cases with them. And so that was, so I was in the right place at the right time to have an incredibly generous teacher who just showed me how to do it, and then the next month showed me, and then that, and so there was a gradual progression. I honestly think with this kind of surgery, there is just no alternative than to spend some time with people.
I just was thinking about how about using a goat or a sheep cartilage for carving?
You could. I'm not that familiar with goat or sheep rib and how it behaves. If it behaves like adult rib, it will be significantly more difficult. One of the great things about operating with children is that their costal cartilages are just beautifully homogeneous. So they don't have a medulla. You know, if you take an adult rib, it's got a medulla. It's almost like hollow, or sort of it's almost hollow in the middle, and if it's not sort of ossified, and actually doing adult reconstructions can be really tricky. So I think if you've got a sheep, if you've got an adult sheep or an adult goat, and their ribs are anything like an adult human, then actually you're going to find it tricky.
The reason why I asked is because the carving is very important. So
yeah, oh no, it's really
people can try with that, and they can initially to get that.
Oh yeah, I think one of the other things that's really difficult is, I once again, this would come down to my knowledge of the anatomy of the sheep rib cage is limited, but getting the block right, you know, because actually if you get the block shaped right, and then you can then wire the other bits of cartilage onto it, then life gets a little bit easier. So I'm not sure if there's a particular bit of the sheep rib cage which replicates that rib junction, if that makes sense. But I mean, goodness, people are eating sheep, people are eating goats. Why not have a go with the cartilage, eh?
Yeah. Other question is any alternative for steel wires?
Not that I've tried. I don't use steel wires exclusively, and sometimes if I'm doing a delicate bit, so if it just at the tip of the floater, where it just you want it to just lower down on the helix, you want it to fade in nicely. Sometimes I would just use a bit of PDS because I'm slightly anxious about having steel wires very close to the surface of the skin. So sometimes you can use some PDS, and I did have someone who lost a tiny bit of skin just over a steel wire, which settled down when I took the steel wire out. So some PDS can work, but in general, for most of it, using the steel wires is a really neat way of doing it, because you have two needles that you can put through, which means you can position your cartilage and just sort of nail it exactly where you want it to, which works really well.
Thank you. And the question to Dr. Herman, this is regarding the non-surgical technique which you showed, and the results were excellent. And I haven't tried personally so far, but is it only the 2 weeks is enough, Dr. Herman, for this strapping?
You're muted, doctor.
Yeah. Normally 2 to 3 weeks. It depends on when you start. There is a rule that it says you have to tape as long, double the time that, or 3 times the time that of your age. That means when you're 1 week old, you tape for 3 weeks. If you're 2 weeks old, you tape for 6 weeks. Actually, you don't fulfill it. 3 to 4 weeks is fine. If you have microsa, like I showed in the presentation, that took 4 to 6 weeks to keep it in the position, because it is strong malformation. Well, that's the rule. The best time is to start at the very beginning. It is no bothering for the baby. That's it. And it costs nothing. Only, I always say, a little bit of brain. That's it. A brain and a small piece of tape.
The other important question in non-surgical one, which I thought is this thing, how do you assess this 1 week, 2 weeks is enough, 3 weeks is enough? Because when you remove the strapping, you will see that there will be a fold will be there, but after sometimes because of the elastic recoiling, it can go back. So how do you assess we need 1 more week or something like that? Is it by?
In general, the mothers are very clever, in general, really. And I tell them, when the tape comes off, leave it for 1 day. If the ears start protruding again, tape it yourself, because I teach them how to do it. And it's easier to teach mothers than doctors to tape it because they are interested in it. They want to have their baby better looking. And then when it stays in the position, you can stop taping.
So ideally, for 1 day you'll be looking for it. So
yes.
Then you can
you leave it for 1 day without tape, and be careful that the baby doesn't lay in the bed with the ear flopped over the ear canal. That's it. Sometimes they wrap around. This is the only thing you have to take care. And then I tell the mother that they should use a cotton wool cap so that the ears are protected and they don't wrap ahead. That's it. It's very effective.
About the scoring technique also, the same thing you said, the strapping, that pressure, 1 week is bandage, and for 2 weeks it's headband, you use it normally. This is the routine protocol you have for all the patients, or it differs?
No, you see, for the presentation I have to just speak in general. Okay. In real life, it is when the patient comes and I take off the bandage after a week. It's only to prevent hematoma, and I tell you, I have no hematoma. Only if the cotton wool of the concave cavity is removed by the patient himself, because it's itching or tickling or what, then they fiddle around, it comes off, then it can be a hematoma. Actually, it's not so. Not that problem. It's the same like in reconstruction, you get a hematoma when you don't have a compression, either have a vacuum from inside or a compression from outside. So until, let's say, 5 to 6 days, you have to have the skin on the cartilage where you want it to be further on. Well, once again, is there anything, I forgot now because of the hematoma. If you take off the bandage after a week, then you see the ears look fine. And very often I tell the mother, look at the ears, how they look like now. Take a picture of yourself and watch it. If there's a problem, next day, put a headband on. Or for safety reason, just to preserve the shape, overnight, put the headband on. But if the ear is fine, you don't need to do it after, let's say, for 2 weeks, have the headband overnight, and then not even overnight, no headband at all. But for security, I would recommend it, because children, and I noticed even adults, because I'm not only operating children, also adults, they are used to sleep on their ear flapped ahead. And this is a problem. In the beginning, because they feel comfortable in that position, because since childhood they did it. And in the beginning, it's hurting. There is pain if they want to put it ahead, so they don't do it. But let's say after 3 weeks, there is no more pain, or actually there is no more pain after 3 days. But after 3 weeks, they feel comfortable with, and then if they can't sleep, then they go back to the old habit and put the ear and flap it over. So this will not result in a good shape of the auricle.
And how much rasp you do on the cartilage? You said the bending, you said this thing. Is there any feel when you do that? Is it, do you have a, sometimes you will see that the thinning, you can see that pressure, this thing. So how much you recommend that is apart from mending?
I told you the two videos of the anti-helix before filing and after filing. The key is that the elasticity is reduced. You should not interrupt elasticity. You should not file through. And that's why I tell you the cartilage is so different in the lower part, in the lower third where the anti-helical tail derives. There the anti-helix is very thick, whereas in superior cruise, the cartilage is so thin when you do some, for instance, some scoring, you have to be careful not to cut through. It is really sometimes fragile, thin like glass. And then sometimes I did an endoscopic view to see how much I did the abrading. Actually, you couldn't see it. You couldn't see any abrading, but still you could see that the elasticity is gone. I have, in old presentation or in the publication, I have some pictures of the cartilage before filing and after filing. You don't see any difference. The background is in histology that on the, if this is the thickness of the cartilage, you see, this is the anterior side, the posterior side. Outside and inside, there are elastic fibers in between, they are getting less. So here, lots of elastic fibers getting less and getting more. So when you reduce the elasticity on one side, the elasticity of the opposite side will pull. That's it. That's the effect of the filing. You can do the scoring. Everybody knows what happens. Gibson and Davis was presenting this long time ago, how the cartilage responds to a treatment. Filing, scoring, but suturing or the filing front behind to get a round anti-helix, really, this is a fairy tale. You don't get, when you file the cartilage from behind, you get a very sharp edge on the anterior side. It's, no, it's not recommendable. And by the way, foreign bodies in the auricle are different than in the nose. The nose has much thicker skin than the auricle. The anti-helix is so thin that you see every scoring or sometimes even pinching of the needle to reduce tension. You can see through the skin, not immediately because everything is swollen, not after a week, but let's see after a month. Oh, what is this? Doctor, look how strange it looks like. This is where the problems come. So if you want to have a nice picture, take it of 1 week after the operation, looks great. But let's say 1 year after, then there is a difference. And this is why I'm so proud to present long-term results, because I can show what works and what does not work. I have taken out so many sutures of the suture techniques. And this is why I'm very restrictive to foreign bodies.
There are another two questions which I would like to ask Dr. Rahman. One is regarding the rasp. What is the size of the rasp which you use? You said it's a
size is about 1 centimeter in diameter. Let's say 1.3 millimeters long and 10 millimeters in the width. That's it.
Another thing, did you ever use other techniques for your failure cases? Or
yeah, of course.
How do you?
I never tried the cartilage cutting technique because this is the absolutely worst case you can do it to an auricle. To cut the cartilage, you get very synthetic look and you hardly can repair it. The effort to repair a cut anti-helix is so much bigger than to do it properly in the beginning. And by the way, I've checked about 1,500 ears for what I did in them. And I found out only 10% of the patients have underdeveloped anti-helix and 10% have a hypertrophic concave, overdeveloped concave cavity. And all the others, all the 80% in between, are a mixture of this. So only antihelix is poor, and concave cavity is also very poor in the representative number. You see, and when I correct the antihelix, like I saw with the clip, the ear fold, you can address the antihelix, absolutely right, but you should not forget about the inferior cruise. And in one of the pictures, it was really nice to see that you made a result like I showed with the 4 different kinds. You should not forget about the inferior cruise, because you get an unnatural look when you only squeeze the superior cruise and the helix, and some of the auricles have a malformation so that the inferior cruise derives a little or joins a little bit shallow to the antihelical body, and this makes a very unnatural look. That's it. So you have to regard it's not easy because it is so complex, and you have to have a feeling on what fits together. I cannot, as I told you, only 10% address antihelix only 10% antihelix concave cavity only, and all the others. By the way, it takes to correct antihelix, inferior cruise, concha, and lobule takes me 45 minutes for 1 year. So this is not much. I mean, sorry, for both sides. The problem is the anesthesia. It takes about 15 to 20 minutes to make the children awake. And from the year of 12, I do the operation in local anesthesia anyway. That is much faster.
Is there, in your experience, is there any technique to maintain the symmetry of the ears?
The technique to get a symmetry is that you have nice eyeglasses. I mean, yeah, that works together. Your eyes are helping you. Yeah. I always become so angry when some colleagues say, yes, you have to measure the distance of the helical rim to the mastoid. You can do it, but it doesn't make any sense. The patient does not go to the mirror and measure how much his ears are protruding. He wants the front view to be nice. That's it. Because there is very often, and I've checked it, but it would make the presentation so long. I have many pictures of children with asymmetric skulls behind. The mastoid is in a little bit. The front view looks nice, but the posterior view looks, not really symmetric. But it is the front view that makes the patient happy, not the view from behind. But still, I claim it is important that the view from behind is not irritating, because when somebody looks at him from behind and says, oh goodness, you have so many scars and keloids and hypertrophic scars and contraction, that was an autoplasty, wasn't it? So this is what I mean. You have to have a 3-dimensional impression of your auricle, of the result of your autoplasty.
Thank you, Dr. Herman. The question for Dr. Alam, the technique I saw, it was nice. That is, you are using the
earfold.
Earfold. Is the titanium the locks, when you shoot it, does it correctly locks it, or it can go? Sometimes what happens is, if it slips or when you don't press it properly, it goes and stucks and this thing. So what happens is, the next thing that will happen is the damage to the cartilage if it is not done. How do you manage this? Is it right what I'm saying? Is it the common?
No, it never gets released while you're inside the wound because it's such a small area. But the problem is sometimes if you press it, it's quite delicate. So you can actually prematurely shoot it off, such that basically it goes flying before you even get into the ear canal. But once you're in place, because there's a three-part mechanism to it, so it's actually quite hard to just suddenly release. So once it's between your fingers, it's not going to go anywhere, and it's already gripped the cartilage. So the tines have gripped the cartilage first, then it's released. But the problem is if you've accidentally just handled it too much before you've gone in. So right at the very beginning, people have seen implants flying off elsewhere. Then you've lost an implant, so you have to get another one. So
I have one suggestion in this technique. Whether I don't know whether it's really useful. Instead of putting the that is at a horseshoe shape, that is this thing U shape. If you have something like a I shape or T shape, which is goes and stucks like that, is there any possibility so that you don't see the projection of the? I have seen in your few photos, titanium implants. Normally, I do a lot of facial trauma. So when we use plates over the orbital rim, people feel that, or sometimes it's palpable. The same case for you also in this. I've seen a few cases which you also mentioned that. Is there any way, so it's like a clip, which is you have a natural cartilage above and just a T shape or I shape, the modification in the equipment. Is it possible or something like that? Have you tried something?
No, certainly not tried anything because it takes so long. It took 12 years to get to this point. So adapt it would be a nightmare. But I think, there's lots of things one can do because actually, the antihelix isn't a U shape all the way through. It's kind of near the superior crus, like a U. And as you get more kind of inferior, becomes a bit like a V. So actually, you have to kind of adjust it. Norbert actually, when he devised this, he had 6 clips. So the initial pilot studies were using 6 different clips on 6 different sizes, essentially. But it turned out that the middle size, this was the size 3 of the 6, was the one that seemed to fit the most. But it's about changing the position along the helix. So I think there's lots of options, and some of the modifications Norbert's done himself afterwards to reduce any kind of like palpable or visibility issues is that he's sometimes put some things like permacol and sort of dermal layers over the implant. But I think the way I would see that just adds too much hassle to this procedure. The reason why this has been popular is because patients want something simple. So if the more complicated you make it, the less popular it will be. So they will just have essentially a normal surgical otoplasty. But I think, but as with all these things, all in the consent process at the beginning. So you discuss all these issues, discuss potential visibilities, all those things. And but for me, what's been the most appropriate thing about it is that pre-fold bit, because all of you who do facial plastics, it's that discussion afterwards, especially with rhinoplasty patients. I'm sure it's just this allows you to get in their mind, and they're in control. They see the imperfections and they're willing to accept it.
Okay, what is the size of the thickness? What is the size of the implant?
0.015 millimeters in that situation. So it's basically very, very thin. So if it's actually put it in flush with the cartilage, you shouldn't be able to feel it afterwards.
And is it it's the stability of the implant? Is it because when the ear movements are there, is the implant breakage or something like that? Do you have any complications you've seen there?
Because the thing about nitinol, it's this, I think as mentioned, it's super elastic and fatigue resistant. So it's engineered multiple times over. So they guarantee it for a lifetime of a patient. So literally the patient could do this forever and it's not going to snap in that situation. Not to say they can't, if they go and play rugby or if they're boxing, then those things can, may cause an issue, I guess. So we warn patients about that. But actually there's no, after the initial post-op period, after about 6 weeks or so, they should get back to normal activity and not worry about, contacts and things and wearing helmets or contact sports.
Another last question, which why do you use nickel with the titanium? Is it, that's what I think your combination. There should be a reason.
The main reason was those facilities it has. Like I say, it's just that it's super elastic, fatigue resistant, and also it's tried and tested in the body. It's kind of a standard, prosthesis that's used in orthopedics, in heart valves. So in terms of getting license to go ahead and do these implants, it just basically much easier. But actually, the properties of the material works really well. The only downside of it is it's quite dark grey, which is why it has to be gold plated. So under fair skin, you might see a rectangular shadow.
Okay, thank you. Thanks a lot.
Alam, excellent presentation. Very nicely, explained the procedure. I've just got one question. I know you mentioned that more and more people coming in, in 40s and 50s coming for ear fold. Is there any upper age limit? Like what I was thinking is the cartilage tends to be a bit more brittle when they're old, and also the skin gets more atrophied, isn't it? Like the skin tends to get more thin. So do you set like age, or is it just a clinical decision?
It's just a clinical decision. There is no upper age limit. And certainly the oldest patient I've personally invited was a 64-year-old. I know Norbert's done a 73-year-old. So it just depends who comes. And the real question is why they're coming at that age. That's what kind of interested me at the beginning. But it was exactly what I've learned is that there's this, like I say, this latent group. So people who've sort of been bothered about their ears, but they were never bothered enough to do anything about it. And like I say, they're not blaming their ears and why they haven't got a girlfriend or boyfriend or why they haven't got a job. They're the worst type of patients, obviously. They're never going to be happy with surgery. But it's whether they've got disposable income. And I think what it is, something's come along that they've read about, they've seen, or they've been advised about. Hang on, I'll give this a go. If this works, I'll go ahead. If it doesn't, they literally leave the consultation thinking, well, that's fine. I'll just stay as I am. So there's no upper age limit. There's a lower age limit, which is 7, and that's simply because the pilot studies, didn't go lower than that. Plus, also that whoever you do it to has to be able to tolerate a lignospan injection in the ear.
Yeah.
So,
I liked your phrase. What you get, what you see.
Yeah.
Wish we could do something for rhinoplasty as well.
I'm sure you know the pain of rhinoplasty patients.
There's no way we can use the software for rhinoplasties. We can show them, but still, we can't achieve that. We can't match that, and the patient won't be satisfied. So that's yeah.
I think that's what I liked about this. And I think what it's done for me, as I said, I didn't have a major otoplasty practice before this at all. But what it's done, because patients are finding out about this, they come to you to discuss it, and it may not be appropriate for them, but then they're your patient now anyway. So actually it increases your practice. If those of you who do otoplasty, if this is something you offer, it just basically creates a footfall your way. And it might be that only 20% of patients actually convert to earfold, but then you've gained them for other things. So actually it's been a learning curve. It's interesting, but it's really industry. If you all have the idea, it takes ages to get out there, and you just got to persevere.
Yeah. I think it's a simplicity that makes it, isn't it? Like I think that's what drives the people. Yeah, that's great. Actually, yeah.
By the way, I would like to mention the adult people that I operate in my office. They all get a mirror in their hand during the operation. I say, now have a look. Would you like this? Would you like a little bit more, less? Okay. Yes. We're discussing like this, but you can't do it with children. So this is nothing special. If you make a procedure in local, it's much easier. In rhinoplasty, well, that's a little bit more difficult. Well, that's it.
Yeah.
Dr. Ronig, I have a question for you.
Thank you. Please.
Yeah. I must mention over here that I'm hearing a lecture for third time in webinars. Yeah. I have a small query. Do you anytime stage the procedure for the antihelix and the concha? Dr. Ronig?
Yes, I do. I don't understand what you say. The procedure for the antihelix is what?
Yes, and the concha. Do you at any time stage the procedure? Meaning, do the antihelix first, and then after some time do the concha.
No, first I do the antihelix. Then I see how much the antihelix is spending. Then I put down the concha to put the setback.
At the same stage.
Of course, at the same stage, not of course, yeah, the same stage. It takes for 2 years. It takes 45 minutes to get the as well concha setback, antihelix filing, and inferior cruise if needed, and lobuloplasty. So it's all done in the same stage. But the patient is shown the mirror at the end of his stage. So to show him, or just before, would you like to have this one changed too? and I pinned it. How would you like to have it? It's like, I always compare it with a butcher. When they slice a piece of a sausage, would you like some slices more, like this? It's similar with the oracle, some more setback or less setback.
But how do you judge? Yeah. And how do you judge the amount of skin to be excised in the post-auricular region? Because the skin is known to stretch.
The problem is that with the suture techniques, they excise so much skin. And honestly, I have to say, 25 years ago, I did the same. And I saw the result because I controlled my patients. And now I make a skin excision of about 1 centimeter, 5 to 10 millimeters, post-auricular in the post-auricular sulcus, because the absorption of the skin, if not needed, will be done after a year. But the more tension you put on the skin, the higher is the risk to get keloid formation. That's the problem. Hypertrophic scar and keloid are results of tension. Of course, genetic disposition, but also tension.
Thank you. Thank you.
You're welcome.
Yeah. I think any questions from Jerry? Can we closer?
Yes.
On behalf of Isfaro, I thank all the three speakers for giving and good discussion. We had a different techniques. We love to watch this. And I thank moderator Dr. Bhaskaran, Jerry, Dr. Kavya, and Dr. Anbu, Dr. Mohan Jagde, and our Isfaro team. And I thank our academic partners, Medinews Pharma. And behalf of Isfaro, we will see you on Monday, that is on 28th March, with fourth and final session of aesthetic surgery webinar series, facial reanimation. See you then. Bye.
Thanks, everyone.
Thanks.
Bye.
Thank you. Thank you.
Thank
And
you.
good night.
Bye-bye. Bye-bye.
Thanks.
I see you. Thanks a lot.
Thanks for inviting me. It's great.